We are ready, sir. We are on live. We can start.
Yeah, good morning, madam. Good morning, Rohan sir. Good morning, Nandita madam, Asa madam. Welcome to this program and thanks for taking time for this talk on the Senora Summit. It is a West Zone. We are covering Maharashtra, Gujarat, MP and Chhattisgarh in specific, and all India also we have circulated this invitation, madam. So just to introduce our moderator and coordinator, Dr. Rohan Palsetkar. I think this is I am sharing this slide. It is visible.
No, it's not. I'll just share it. It's okay.
Now it is visible, sir.
I'm
Yes.
sharing my screen.
Yes, it is visible. I don't know from which screen.
Okay. Just to introduce Dr. Rohan Palsetkar. He is the head of unit Bloom IVF from DY Patil. He is the second joint secretary of AMOGS and joint treasurer of Maharashtra chapter of IH. He is the managing committee member of MSR, that is Maharashtra chapter of ISAR. He is the managing committee member of MOGS, associate professor of DY Patil School of Medicine, and he is a recipient of Foxy Corion and Foxy Santi Yadav Award for Infertility. He is also a recipient of AOFOG, a Young Gynecologist Award 2019. He is an ISAR Yuba Orator for 2019. He is a Foxy Yuba Orator of 2020 and a recipient of MOG's Best Youth Council Member Award 2016 and 2019. More to it, I will add Dr. Rohan Palsetkar is a personality or a figure which is well known to everybody among this gynec fraternity because of its very cool and very appealing and very pleasing personality. More to it, the most appealing part of Rohan sir is his smile. So over to you, sir, to carry forward this session of the Senate Summit West Zone.
Thank you so much, Saminji. So everyone, welcome to the Senora Summit. And I would like to thank Sunpharma Senora Division for helping us create this program and bringing this academic aspect of OBGY to you to update you with the latest advances in the field of OBGY. We have some eminent faculties which you will be hearing throughout the day over the next 2 hours. Before I start with the faculty, I want to introduce my co-moderator for the session, Dr. Jitika Thakkar. She's a consultant at Bloom IVF Leelavati Hospital, Mumbai. She's a consultant obstetrician and gynecology and infertility specialist at Kedia Nursing Home, and she's an active youth council member of the Mumbai OBGY Society. She's also won the Professor Khurshid and Dr. Sonu Shariar Best Youth Council Member 2016 and 2019. And she's also a medical reporter of the newspaper Vidarbha Ka Dhara in the Vidarbha region. And she is very active in presenting papers and posters at the national and international conferences. So, Jitika, looking forward to your co-moderation with me for this entire program. So, without taking too much time, I want to introduce our first speaker. That's Dr. Nandita Palsetkar. She's an MD, FICOG, FCPS, and a FRCOG. She's received a FRCOG from the Royal College of OBGY, UK. She's a director of 9 Bloom IVF centers. She's also a professor at DY Patil Medical College, Navi Mumbai. She's a teacher for the super specialty degree FNB Reproductive Medicine. She's been practicing infertility for over the last 25 years. She's the current president of AMOGS, the immediate past president of Foxy. She's the past president, and I think she's giving me a sign from here. She's right next to me while we're doing this. So I think I'm going to hand over to her to start her presentation on endometriosis.
I have to start sharing the screen.
Yes.
This one? Yeah. Share first. No? Yeah. Is my screen shared?
Yes, madam. We can see.
Great. 1 minute. Let me reduce this. Can you reduce this?
Yeah.
I want this to go away. This. Okay. Hi, good morning, everybody. First of all, I think thank you to Sonora, Sun Sonora, that it's doing a wonderful job. And I really am very grateful to Rashmi Parekh, and Somin, who have done a wonderful job of getting so many states together. And for me, endometriosis is something I'm very passionate about, and it's very close to my heart. And I've been, treating lots of patients with very good success. So whenever anybody tells me talk about endometriosis, I am happy. In fact, Rohan has been telling me, "Mom, am I going to tell you when your time is up?" Yeah, you have to tell me when my time is up because I can talk for hours and hours. And it's good to see my friend Asha on the screen over here. So, and looking forward to interacting with all of you all after the session is over. So, endometriosis causes infertility in many ways. It affects everything in the reproductive tract: ovulation, then the sperm survival, altered immunity. Peritoneal factors cause intraperitoneal inflammation, local production of prostaglandins, cytokines, endometrial dysfunction also. Then mechanical factors like anatomical distortion of the tubes, altered tubal motility, interference with ovum pickup, peritubal adhesions, coital function is disrupted, and even sperm inactivation by phagocytosis and antibodies. So, if you look at this disease, it's a disastrous disease where infertility is concerned, and we need to understand that the pelvic cavity, in this case of endometriosis, contains increased hyperactivated macrophages, which produce cytokines, and the negative effect on the follicles and the oocytes, and they create a hostile environment for fertilization. In addition, the endometriotic lesions produce different cytokines such as interleukin 1 beta, interleukin 6, interleukin 8, and tumor necrosis factor alpha. All these are harmful, and they are anti implantation factors. So they lead to implantation failure and spontaneous abortion, and even not only in natural pregnancy but also in IVF procedures. There was this beautiful study which was published in 2018, Fertility Sterility by Isel et al. And there were 80 patients, 40 with endometrioma and 40 age-matched healthy controls. And expectant management was done. There's always been a kind of a debate whether the old timers will say, "Oh, we've left our endometriosis patient surgery and left them alone and they've conceived." And now with the new ovarian reserve markers, I think new insight has come into endometriosis. And here in these 80 patients, expectant management was done. And serum AMH and antral follicle count was done 6 months apart. And serum AMH dropped in the study group by 26%, while in the healthy controls it was only 7%. AFC also dropped from 10 to 8. So women with endometriosis experience a progressive decline in AMH levels as compared to healthy women. And this is something we need to remember in patients with in the reproductive age group. So if I consider my patients, I would like to divide my patients into an adolescent endometriosis group, an infertile, and recurrent endometrioma. Remember, these are the three groups where there is impact on reproduction, and that is what we need to really remember. So this is a simple chart. Actually, if you understand this, you don't need to do anything. So you have an infertile woman with suspected endometriosis. Do an infertility workup. If there are other indications for IVF, like a low sperm count or tubes are blocked, then they obviously go for IVF ICSI. But if those indications are not there, then please, the first thing in a reproductive age group that you need to do is an ovarian reserve test. And today what is available is an AMH and an antral follicle count. And if any of your patient has a poor ovarian reserve or she's an older age group, the idea is today, evidence-based medicine does show that she will benefit straight from IVF ICSI. So this is something I want you to, understand and maybe think about it and ruminate over it. This is how the treatment of endometriosis has changed now. So, ovarian reserve tests, suspicion of minimal or mild endometriosis, if she has a good reserve, then surgical treatment is a good option. And then you can do COH plus IUI for 3 to 6 cycles, and you can get good results. If she doesn't conceive, then go for IVF ICSI. If you think there is a moderate to severe disease, again, you can do a specific decision. If the patient is young, I would do surgical treatment, try IUI, and then if she doesn't conceive, go for IVF ICSI. But if she's on the borderline, the AMH is just on the borderline, age is on the borderline, I would take a very patient-specific decision depending on the size of the endometrioma, etc. So we'll go through the next part of my talk, deciding all those things. So I think in the surgery, cystectomy is the most relevant part of the surgery, because cystectomy is something that reduces your ovarian reserve. There is no question about it. In the surgery, if there are peritoneal deposits, etc., they need to be ablated or fulgurated or excised. So you can go ahead and do that. But when it comes to the ovary, you have to be careful. And it has been observed that the ovarian reserve definitely drops after a cystectomy. And remember, it drops correlated to the amount of the tissue that you damage. And if the amount of the tissue that is damaged depends on the endometrioma dimension and the use of preoperative suppressive therapy and perhaps the surgeon experience. Now, this is something very important, because in the olden times, we used to give GnRH analog before surgery. But that is not a good idea because it causes more damage. Then techniques to decrease injury: minimal use of electrosurgery, precise hemostasis, use of alternative methods to electrosurgery, such as the hemostatic agents or suture, or even the laser is shown to be a good agent. Effects on cystectomy AMH levels. I think this was a 2019 study, which was really good. It was good because it differentiated that bilateral endometriomas, AMH decreases significantly when you do a cystectomy. Cyst size more than 7 centimeters, it decreases more. Coagulation is worse than suturing, and also that a short-term decrease is seen with single unilateral cysts, and maybe the recovery is complete within 1 year. So if your patient is young with a unilateral, you could try controlled ovarian stimulation with IUI in this kind of a patient. So live birth rate after surgical and expectant management of endometriomas in IVF cycles, a meta-analysis. 30 studies were included, and the number of patients were nearly 3,000. Live birth rate was similar in both groups. So surgery or IVF. So you do surgery, and then whether you do expectant management or IVF, if you see that the live birth rate was similar. So whether to undergo surgery in a particular patient or to go straight for IVF is a decision which is very patient specific. And as I told you at the beginning of my talk, I think we should pin it on whether it's severe endometriosis and poor ovarian reserve. Oocyte cryopreservation is something that I feel from the bottom of my heart that we should offer our patients. And there was a beautiful article by Anna Cobo in Fertility Sterility. I think it was in the July 2020 Fertility Sterility, which was a 10-year observational study. And she had 485 patients where fertility preservation was offered to these patients with endometriosis prior to surgery in the young women. Of course, older women, individualization is necessary because depending on the age, how much can be reserved. Now, let's come to the ASRM and ESHRE recommendation, which really created a furore. It created a debate between the endoscopist and the reproductive medicine specialist. And I think I'm coming to see the wisdom in it. And what it said was the only indications for pre-IVF surgery are. So you have to understand that once you've decided that the patient is going for IVF, then in that subgroup of patients, the indication of surgery is only if she has pain or to improve access to follicles. So do not do surgery if you think your patient should go straight for IVF unless she has these two problems. Okay, that was the gross points of different treatments that were available for endometriosis. Let's now tackle the special groups. The adolescent endometriosis. So we have medical therapy and we have surgical therapy for this set of group. So why is adolescent endometriosis so important? Because the recurrence after laparoscopic surgery is as high as 30 to 40%. And there is no factor which actually guides you that there could be recurrent. So if you have done surgery in any patient, medical therapy is very, very important, and follow-up is very, very important. And these adolescent endometriosis group, the minute they reach 20, 21, if they have a good AMH, I think you should offer them fertility preservation. So what are the medical therapies that are available to us? I think what we are currently using is Dynogest. And I'm very happy with it, 2 to 4 milligrams per day for 6 to 12 months. Then oral contraceptive pills, but I think you should give them for 4 months and they give very good results so that you don't get frequent periods. Then oral medroxyprogesterone has also given good results. LNG-IUS, I do not use it in this young group, but it can be used especially in older patients who have adenomyosis also along with it. Mifepristone for 6 months can be used. Cabergoline twice weekly for 6 months. Leuprolide acetate 3.75 milligrams monthly injections can be used. So GnRH analogs. I want to a little bit talk about the new things on the horizon. Elagolix, which was a double-blinded RCT phase 3 trial, 150 milligrams, 200 milligrams. They were effective in treating endometriosis-associated pain. Elagolix has a short half-life and concluded twice daily dosing was more than ideal. And the new drug is Linzagolix. This is a study by Donay et al. He has taken 328 patients, and 50, 75, and 100 or 200 was administered once daily for 24 weeks. And it significantly reduces endometriosis-associated pain and quality of life at these doses, but it also decreased BMD. So you have to be careful that these are the new drugs that are coming and we could use it. But the one which is tried and tested has been there for a long time, and especially in infertility, is something that is coming up, and we need to be aware of it, is cabergoline. Because there are, at times you want to give it to the patient and you want them to conceive. So this is something that can be used. You know, cabergoline, what it does, it reduces the phosphorylation of the VGF receptors to reduce the gene and protein expression of this growth factor. And that's why it's anti-angiogenic. So what it does is it causes endocytosis of the receptors. And this VGFR receptor is reduced. So it obviously reduces the interaction of the VGEF action with its receptor and reduces the neoangiogenesis and causes the shrinkage of the endometrioma. So this was an article which was published in 2018. This was an Indian author, and they had total 80 patients, 40 who used medroxyprogesterone acetate and 40 who used cabergoline twice weekly, 0.5 milligrams for 12 weeks, and they found that both were equally effective. Then the other study is where they compared GnRH agonist to the cabergoline, and cabergoline was twice a week and GnRH analog once per month, and they were both equally good and cheaper. Cabergoline was cheaper, easier to administer, and plus you can give her even if she has infertility. Foxy has come up with guidelines, the Foxy Endometriosis Committee in 2014-2016, that cabergoline can be one of the treatment options for medical management of endometriosis. 0.5 milligrams twice weekly for 3 months reduces the endometriosis-associated pain in early lesions and does reduce the size of the endometrium. Then dopamine, this is a review article which says that in endometriosis fertility, patients who desired fertility, cabergoline offers a clear-cut advantage over the other forms of therapy which are available, which delay conception by other mechanisms of actions. Cabergoline can be used pre-operatively, post-operatively, alone or in combination with COCs. No adjuvant therapy is needed as it does not bring about hypoestrogenic or bone density changes. Now let's go to the reproductive age group. Spontaneous pregnancy is possible, but you have to do the endometriosis fertility score, which means you have to do surgery. And if the score post-op was 0 to 1, pregnancy was 0%. But if the score was high, you definitely get patients pregnant. And I think the ovarian reserve test pre-surgery and post-surgery is very, very important. So please do it, because for medico-legal reasons also it's important. And the ESHRE guidelines of 2013 say that IU definitely increase the live birth rate in endometriosis 5.6 times more in grade 1, grade 2 endometriosis. And in fact, in grade 1, grade 2 endometriosis, it is important to treat because of the SIRT1 and BCL6 the receptors which were activated, and they have a very bad effect on implantation. Then, does the surgeon matter? Definitely, the level of expertise definitely matters. And this article by Muzi et al. Muzi is a histopathologist who's been working for 2 decades on, cyst walls which are given to him by the surgeons. And definitely, he has shown the more experienced the surgeon is, the less damage to the ovary. This is something new which I came across. I am not promoting it, but I feel that there is a chance to explore this, because I have a lot of patients who've had recurrent surgeries have come to me. There are large endometriomas, and I need to reduce these endometriomas in order to do IVF without damaging the ovary. And sclerotherapy is a non-surgical therapy included in the expected management. It's a promising technique to reduce recurrence. They use a sclerosing agent. Ethanol has been used, and a few people are using it even with laparoscopy. I remember, I think there is a publication which is coming from Sandesh, and there is a publication which is coming from one of the persons abroad who's done a lot of work with it, and I'm waiting for it to see what results it gives. And this meta-analysis and systemic review by Aviad Cohen in July 2017, fertility, sterility, showed that recurrence rates post sclerotherapy were very variable, because ethanol washing was done. Ethanol washing has a high recurrence, but ethanol retention just for 10 minutes has a low recurrence. Number of oocytes retrieved higher with sclerotherapy as compared to lap cystectomy. However, the clinical pregnancy rates were similar. Sclerotherapy versus no treatment, no difference in number of oocytes retrieved or CPR. Conclusion: sclerotherapy may be considered in symptomatic women who plan to conceive. So I think the jury is still out. I am not recommending it right now, because you have to take a lot of precautions, because infection is a major worry. This particular meta-analysis showed that if you take proper aseptic precautions, give IV antibiotics, I think it works. So we still have to wait and see. What do I do in my cases when there's an endometrioma and IVF? Antagonist protocol with freezing, embryo pooling if the ovarian reserve is low, and then I do frozen thaw embryos. But prior to doing the frozen thaw embryo, I give 2 cycles of GnRH analog to ameliorate the effect of endometriosis on the endometrium. And during OPU, if I encounter endometrioma, I avoid aspiration and puncture, but definitely admit the patient for IV antibiotics for 24 hours. And, as I said, sclerotherapy is like how we do an accidental puncture of an endometrioma during IVF. We don't get abscesses because we keep the patient. We give her 24 to 48 hours of antibiotics. And in fact, during pickup, we don't even use antiseptic to clean. We use normal saline. So when you are aspirating, you probably clean it with betadine, etc. So there are these thought processes which are there, and we need to think about it. So as I mentioned, if there is an accidental puncture of endometrioma during an OPU, change the OPU needle, and the egg retrieved is kept separately. Age and number of eggs, I think if my patient is younger than 35, 5 oocytes are enough to give me a pregnancy. But let me tell you, I had a patient, in fact, she was one of my very close colleagues who had endometriosis, and we got one good embryo, and she conceived twice, had had 2 children with just one good embryo. She was 31 years old. I think that is so very important. The age is important. So please do not waste the age of your patient. It's very, very important. So 38 to 40 years, 7 eggs are required. 41 to 42 years, 10 oocytes are required. And more than 42 years, 20 oocytes are required. To evaluate the effect of endometriosis on pregnancy, I think this is very, very important. We only talk about endometriosis and its effect on fertility, but it has an effect on pregnancy also. The preterm birth rate has increased, miscarriage rate has increased, placenta previa rate has increased, small for gestational age babies are born, cesarean deliveries are increased with endometriosis. So we really need to pay attention to a patient who has even conceived naturally with endometriosis and watch out for these adverse pregnancy effects. So friends, I would really like to highlight this slide again, that when you're doing the infertility workup of a patient with endometriosis, ovarian reserve test is the first test. So poor ovarian reserve and an older age group go straight for IVF-XC, because this is the chance you're going to give her of producing a baby which is genetically hers. And if you have adolescent endometriosis, give her oocyte preservation. If you have a young girl with endometriosis and she doesn't want to have a child fast, don't advise her, get married soon and have a child soon. That doesn't work with this generation. Advise her fertility preservation, advise her freezing. And there are enough data now available to say that this really works. So please, I want to throw these things open to everybody around and think about it out of the box. So I'd like to conclude by saying individualization is very, very important. What you need to take in mind is patient's age, ovarian reserve. Of course, other factors like male infertility, peritoneal factors, subfertility, etc. Medical management can be considered patients with endometriosis associated pain. I have not considered deep infiltrating endometriosis, but a multidisciplinary approach is definitely necessary. And sclerotherapy is the new kid on the block, can be considered. And, I've been introduced to cabergoline. I've used it in a couple of patients. And today, thanks to Sun Senora, actually, when he made me read about cabergoline, I was thinking about it, and I think that it's a good option in patients who want to conceive. And, we still want to control their, I've operated or I'm waiting for IVF, especially in this COVID era. It might be a good idea to put them on cabergoline, tell them to have normal relations and see if they conceive. So I think it's every time I do give a talk, I think I also learn something new and take home a point. Thank you very much. I think Dr. Rohan and Dr. Jitika, and of course Rashmi and Soman. I, I have not exceeded my
You
time.
have not.
Hi, Asha.
How do I stop
Just
sharing?
stop the sharing.
Yeah.
You need to
Mute.
Thank you so much, ma'am, for such an in-depth talk on endometriosis. And every time I hear you, it's always something new and updated when I'm hearing you speak. So thank you so much. Now on to our next speaker. It's Dr. Girija Wagh. She's a professor OBGYN at the Bharatiya Vidyapeeth Medical College, and she's a consultant at Cloud9 and Apollo Hospitals, Pune. Obviously you can see that ma'am has won a lot of awards, and she has so many things to her name. So I'm just going to quickly go through them. She's stood first in a MD in 92. She's won the Anandi Bai Joshi Award for Excellence in Medical Service. Chairman. She was also the chairman in the Medical Disorders and Pregnancy Committee 2013 to 16. She was the joint secretary of FOXI in 2010, and she's the national mentor of the Lakshya NPO QCN program, Maharashtra government. So, ma'am, over to you for your talk. And obviously, ma'am is standing for the vice president elections from West Zone. So, ma'am, best of luck for that, and over to you for your talk, ma'am.
Thank you so much. Can I have the rights to share my screen?
Doctor, you can share your screen.
Yeah, I got it. Thank you. Are you able to see my screen?
Yes, ma'am, we can.
Okay. So today I have been given the task of talking about prediction and prevention of preterm labor. And I thank the Senora Summit for giving me this opportunity, with the moderator being Rohan Palshetkar. It's always a pleasure to listen to Dr. Nandita Palshetkar with all her updated views, which she's given recently. And I have been on 2-3 webinars with Dr. Kaustubh Kulkarni, and he's really is a encyclopedia of PCOS, I must say, and I love and enjoy talking to him. Vidya Pancholia madam has been my great friend always. Dr. Asha Bakshi is both of us are fighting for the Vice President Foxy elections, and I hope that both of us win this election successfully. And Dr. Manish from my own center. And thank you for giving this 20 minutes of talking on prevention and prediction of preterm labor. And as we all know, that this is a very, very important part of the topic, because if you look at the incidence of preterm labors world over, you'll find that India ranks first and contributes to the maximum number of preterm deliveries in the world. And it is not one or two numbers up, but it is double the second largest China. And therefore, it becomes our bound responsibility to look at this particular incidence very, very seriously. Now, when we look at the major causes of preterm deliveries are PROMs. There can be spontaneous, unexplained preterm labors, but there are quite a few iatrogenic causes. And if you really look at them very closely, you'll realize that there are quite a lot of things can be modified, and we can definitely reduce the incidence and occurrence of preterm labors. So in definition, it is called as presence of uterine contractions of sufficient frequency and intensity to effect progressive effacement and dilatation of the cervix between 20 and 37 weeks of gestation. And it becomes a true challenge because of it being a leading cause of perinatal morbidity and mortality. Most important challenge to modern obstetrics, and 2/3 of the preterm births are spontaneous. And as Madam Nandita said, that even endometriosis beyond guard. So there are so many such opportunities that we get by, and where we have to be careful whenever we are analyzing them, because spontaneous preterm birth is actually a syndrome caused by multiple etiologies, one of which is a decline in the progesterone action, which induces cervical ripening, and we require to look at it carefully. Now, it has been difficult all these days because there has been a cognitive gap, a reluctance to accept the complexity of the problem. And the major obstacle has been that preterm birth is treated explicitly or implicitly as a single condition. And an important step forward would be to reframe the problem of preterm birth to make it tractable. And therefore, this is a new change wherein preterm care does not include methods to predict or prevent spontaneous preterm birth. It is about to change because of two developments: the realization that the sonographic cervical length evaluation in the mid trimester is a simple method to identify patients at risk, and the evidence derived from RCTs and meta-analysis which show that progesterone is effective in preventing preterm births, and of course, screening for genitourinary and oral infections during the pregnancy would help. So, if we look at the entire gamut of things that happen, from infections, vascular causes, to stress, to uterine disease, to cervical disorders, hormonal problems, allergies, autoimmune problems, more than one mechanisms are in play, and therefore it is a good sort of an approach to call it as a preterm parturition syndrome. And this gets classified depending on its gestational age, giving us a better approach to offer our interventions best. Now, if you look at the risk factors, and this is from the up to date 2019, there are a whole lot of risk factors which have been identified by Charles Lockwood et al. Group, which are responsible. And we have to be, therefore, when we are asking to our patients, we must take proper histories and look at all those risk factors which can be responsible for preterm labor, and that can be our starting point to analyze which are the women which are going to be at risk. Additionally, we have to be looking at certain emerging risks during pregnancy, such as preeclampsia, fetal distress, abruption, previa, diabetes, and renal diseases, and we have to deal with them. Now, what has happened in the off late is that screening, as the ACOG bulletin says, can be started at 16 weeks and gestational in suspected cervical insufficiency. So, if you have a history which is projecting towards preterm labor, it's always a good practice to look at this 16 weeks. And of course, we have to do screening for asymptomatic bacilluria by doing a culture sensitivity at 16 weeks. Look for bacterial vaginosis, per speculum, maybe do a Newton score if necessary, guide them about proper hygiene, pre and probiotics, and also look at oral health because gingival infections are known to cause or predispose to preterm deliveries. A lot has been already spoken about fetal fibronectin, but then this is something which is can be used especially in those very high risk women who have recurrent miscarriages or early onset preterm delivery kind of a syndrome, wherein you can use it to determine whether actually the delivery is going to be imminent so that you can give them, offer them a better care. And this is something that has been studied, not very easily accessible to us. There are other biochemical markers which have also been identified, but most of them are used in sort of study analysis and not used much in clinical practice. And therefore, it is important that we look at, if you look at all these studies, we will find that many of them are not accessible. The only thing that we have probably is the maternal risk factors and looking at the cervical length by doing a sonography. Now, lifestyle modification, smoking cessation, modifying physical activity, and then for selected groups, offering cervical encephalage, antibiotics, and progesterone can help prevent preterm births. And we have 3 levels which can be used, like surfactant, corticosteroids, tocolysis, and then we are going to also talk about progesterone today. Now, low dose aspirin has been used in practice not today, but from the 1991. On and off, it has come and gone in practice. And today, if you look at the reviews that are available to us, it has been found that low dose aspirin reduces the frequency of preeclampsia as well as related adverse pregnancy outcomes, such as preterm births and growth restriction, by approximately 10 to 20%. And therefore, this is something that we have to look at. And even the calcium supplementation given as 1500 2000 milligrams of elemental calcium as recommended by the WHO, wherein you can get 2.5 grams from the calcium carbonate and 4.75 milligrams from the calcium citrate, which contains 1 gram of elemental calcium, can be of use because it not only prevents preeclampsia, but it is known to even reduce preterm deliveries significantly. And this has been a result of about 11 trials, 15,275 women screened. And therefore, that has to be something which has to be stressed on. There's something which has come on the block, and this is presented here on this slide because of the Arabin cervical pessary, because it is an RCT. And the RCT has shown its use with a short cervix in this PSEP open label randomized control trial. And of course, it will take its own time to reach to us in our clinical practice. So, what we have in our hands today is ecosprin calcium screening patients and then looking at progesterone as any beneficial molecule, yes or no, because there have been a lot of doubts. And if you look at the pathophysiology of prematurity, you'll find that there is an activation of the HPA axis due to maybe stress, maternal or fetal. There is inflammation, infection, decidual hemorrhages, and pathological uterine distensions, which have been identified. And if you look at this carefully, you'll find that most of this pathophysiology is mediated by progesterone. There has been a pregnant trial wherein it was found that progesterone reduces the rate of preterm birth in women with a sonographic short cervix. And this was a multi-center randomized double-blind study which showed that there was a significant reduction in the occurrence of preterm birth. So naturally, the question comes, which progesterone, the indications, efficacy, molecule, and the route and the ifs and buts exist. Now, the evidences, if you look at, there have been various kinds of evidences which have been speaking about short cervix, history of preterm birth, twin gestation, IVF ICSI pregnancies, in which there is categorically increased rise of preterm births. And it has been found to be effective when given as a maintenance to colysis or as an alternative to cervical cerclage, and this is all well published. Now, how does progesterone act? We all know that during pregnancy it is important for the maintenance of the uterine quiescence, and it has been found in other mammals other than humans that withdrawal of the progesterone initiates the action of the oxytocin. However, probably because we are a very highly evolved race, we have not been able to show or demonstrate such kind of an act, but doing through laboratory investigations. Now, relaxation of the myometrium is brought about by progesterone, which inhibits the connexin 43 gap junction protein, and estrogen is known to increase this connexin 43. And blocking the action of oxytocin, inhibition of formation of gap junctions, and alteration in the progesterone estrogen ratio is known to be the responsible actions. And we know that it acts on the placenta by regulating the CRH in the amniotic fluid, by regulating the prostaglandin at fetal membranes, by blocking the pro-inflammatory cytokines and quiescence at the level of myometrium and the cervix. Various kinds of progesterones are available to us today: the 17-OHPC, the micronized progesterone, and the progesterone gel. And this got back to us in our practice with this publication in 2003, wherein 17-OHPC was studied by this particular group in an RCT, and they found that there was a significant reduction in the incidence of preterm births. But as the research went on, it was found that can we compare this with the natural micronized progesterone, because it was found that 17 alpha hydroxyprogesterone is actually a synthetic preparation which may give rise to other issues. And therefore, we can see that whole lot of guidelines, from the NICE guideline on preterm labor in November 2015 to the guidelines that are from the FIGO 2015, wherein they all have mentioned that women who are at high risk, sonographic cervical length measurement should be performed in all pregnant women from 19 to 23 weeks of gestation by doing a transvaginal ultrasound. And women with a sonographic short cervix should be diagnosed in the mid-trimester, should be offered micronized progesterone. And they have talked about using the vaginal micronized progesterone in this particular study. And it is known to decrease preterm birth less than 34 weeks of gestation. And this was the optimum study analysis, which was a meta-analysis which mentioned that progesterone was found to be effective. The question arises, however, is this really safe? And this is a result of a meta-analysis further. When these children were studied for a period of 2 years, it was found that there was no neurological or any such other kind of a neurodevelopmental neonatal morbidity in these patients, and it established its safety. Then we happened to have the Western Australian preterm birth program promoting progesterone, natural micronized progesterone, and so did the German Society. Now, what is very interesting about this particular guideline is whenever we are studying guidelines, we are either talking of cervical encerclage or a progesterone. And this is the first guideline which mentions that even if you have done a cervical encerclage, you can still continue a concurrent progesterone supplementation to prevent preterm birth. Now, recently, there has been a study by the Ismail et al. After the PROMISE study, which did not actually keep its promise. And we found that in recurrent pregnancy losses, there were not much of supportive effects. But then Ismail study, they decided to study giving progesterone to these women. They decided to study the immunomodulatory and the inflammatory markers in these patients. And it was found that there was a significant progressive reduction in the Th1 cytokines, and increase in the Th2 cytokines is something that we want for the continuation of pregnancy. And these evidences are now well published, wherein we find that throughout every trimester, there is remarkable reduction in the inflammatory cytokines, and progesterone was better found to be effective in these patients of recurrent miscarriages. On one side, we have used acute tocolysis. Now, patient is still premature. And then the question comes, what do we do next? And it has been found that, and this is our Indian study, that you can use progesterone, the NMP, especially as a maintenance tocolysis after the acute phase of preterm delivery has been considered. So once you've given them hydration, you've given them steroids, tocolysis with nifedipine, you can consider giving them natural micronized progesterone till at least 34 to 36 weeks of gestation to prevent occurrence of preterm deliver. And this has been now well studied, and you can see here that in this particular group they have gone and studied the oral micronized progesterone against a placebo, and it was found to be effective because it significantly prolonged pregnancy and decreased the number of preterm births, and the present results support the use of micronized progesterone as a maintenance tocolytic. Likewise, in a twin pregnancy, especially in a short cervix, we can consider using a progesterone rather than a cervical encerclage, because many a times we may think that it is a little too interventional for the fear of causing prom or any such kind of a response. And then there is one more study which has spoken about using, and this comes from Vellore, wherein they have administered this natural micronized progesterone, and they have found reduction in the occurrence of preterm birth. Now, if you look at vaginal progesterone, which has been hugely promoted, the first pass effect of this vaginal progesterone is what has been proposed to be more effective. But the question many a times comes to us is, are all our patients very, very happy using this progesterone vaginally, and especially when you have to ask them to administer it twice in a day? Injectables are painful and are synthetic, while vaginal applications are natural, effective, but cumbersome. And therefore, this is a new formulation which attracts our attention, and that is the progesterone sustained release tablet, wherein it is designed on a special technology utilizing hydrophilic polymers that gradually swell, dissolve, and erode on a continuous basis, thereby releasing the drug in a controlled manner over a span of 16 to 24 hours. And what is wonderful is that it contains to gradually release this progesterone over more than 16 hours in a sustained formulation. And this helps in minimizing the progesterone release in the upper GI tract, which helps to prevent pre-systemic metabolism at several success steps at intestinal bacteria, intestinal wall, and liver. Because one of the important side effects of a first pass metabolism in the gastric mucosa itself is the release of pregnant metabolite, which can give rise to sedation and dizziness. And this is something which is definitely overcome whenever we are giving the progesterone orally in a sustained release formulation. And it was observed in these 153 patients receiving oral NMP 300 milligram SR that drowsiness was much, much less. Now, how does this happen? Because minimization of progesterone metabolism offers more intact progesterone molecule for absorption through the lymphatics in the intestinal or the enteric lymphatics, which ensures that significant amount of drug enters the lower GIT, limiting the effect of the liver first pass and degradation of this progesterone. And when it goes there, it undergoes a micellar solubilization, and therefore an effective, controlled over a period of time, prolonged absorption. And therefore, it, because of its maximum residence type of gastrointestinal contents is in the colonic region, including the rectum, the lymphatic absorption of the drug directly enters the lymphatics and drug through the mucosal lining. And this is the advantage. And the bioavailability of this has been studied in various perimenopausal women, and it has been found to be effective, dose related, of course, with 200 being 20.6, 300 36.1, and 400 46.2 respectively. And if you look at the various preterm delivery issues like tocolysis with atosibine and magnesium sulfate, prophylactic antimicrobials, and maintenance progesterone are the four things that we have in our hands. We can use atosibane in acute needs. However, you have to be careful and you have to be well versed, and of course, the patient has to be affording. I would always look at magnesium sulfate as a go-to tocolytic, because not only does it improve the placental perfusion, but it is also very cheap, easy to administer, and extremely effective, and additionally offers neuroprotection to these preterm babies and can be effectively given. And nifedipine is an effective tocolytic, according to me, given orally, of course, never to be given sublingually, over a period of 4 to 5 days, and then you can continue giving progesterone as a maintenance tocolysis. So the take-home thoughts on prediction would be: current tests for preterm labor would be history, and then investigation, if at all, through looking at infections and the cervical lengths. And we have to have a policy of screening low-risk populations, and subsequent interventions should be subject to a large trial. And we have to look at these various aims at intervention. And I would always like to believe the spectrum of progesterone deficiency proposed by Jerome H. Check, prevention of implantation, spontaneous miscarriage, missed abortion, second trimester miscarriages, preterm deliveries, always are a result of progesterone deficiency. And I would not want to lose that opportunity for my patient. And therefore, I would want to offer them progesterone for better pregnancy outcomes. So, in conclusion, it has a role in prevention of preterm delivery, risk stratification through history and sonography. Its progesterone is safe. Oral sustained release formulation of NMPSR is effective, convenient, and safe. And maintenance tocolysis and prophylactic progesterone needs a larger study to evaluate. So, at the end, healthy babies yield a healthy society, and we have to prevent preterm births to create these healthy babies. And this is my phone number and mail ID in case you require any help or further guidance about magnesium sulfate dosages or anything about progesterone. I'll be happy to answer these questions, because this is a battle that has to be won. No ifs and no buts. Thank you for a wonderful opportunity. And I take this opportunity to reach out to the participants to kindly support me in the Foxy voting. Today is Sunday. The windows are open till 4 p.m. on 10th of September. Please execute your right today and give maximum voting at the Foxy elections. Thank you so much.
Thank you, ma'am. Ma'am, can I just request you to stop the screen share?
Yeah,
Thank you
I'll
so
stop.
much. Ma'am, thank you for such an in-depth look into prevention and prediction of preterm labor. So as you all know, Girija ma'am is standing for the Vice President of Foxy West Zone. So is Asha Bakshi ma'am. She'll be speaking a little later during the program. So moving on, our next speaker is Dr. Kaustubh Kulkarni. He has done his MBBS training from Mumbai University as well as his MD from Mumbai University. He's an elected life member of the Indian Society of Reproduction and Fertility, IISSF. Sorry, my screen just went off. He's also an elected member for ASRM, and he's a life member of the ISAR and an active member of many multicentric trials for ICMR, ISAR, and Foxy. His topic is going to be PCOS and infertility. So can I hand it over to Dr. Kaustubh Kulkarni, sir, to start the program?
Thank you, Rohan, and good afternoon to everyone. To begin with, thank you to the people at Senora for this summit. Thank you to the entire team there, Sapan and his colleagues. Girija, thank you for your kind words, and best of luck to you.
Thank you.
It's always a pleasure to share the screen and time with you. And because you finish on time, I get some extra few minutes to complete my talk. Nandita was good as usual on a topic that she knows. And I'm happy to see that on a Sunday morning, there are a lot of people who are keen to start taking it forward. So Rohan, if you don't mind, I'd like to screen share. So, can you hear me, everyone? Rohan?
Please go ahead, Doctor.
Yeah, thank you very much. What we thought was rather than just talk of polycystic ovary and infertility, which happens very often, we'll slightly sidetrack today's discussion into something that you may face in practice more often than not. I understand fertility is a very glamorous topic and everyone wants to do it. But there are often situations where a woman or a girl may come to you for just cycle restoration. And this is where you have to understand the fundamentals of this problem. And therefore, I thought I'd devote some time to, as I said, the two core issues which we seem to sometimes ignore in our rush to try and get the woman fertile. It is also important because it has long-term consequences on her health. So let me see if I can put it in good perspective for you. So the perspective that we need to have now and in today's world is, think of the pandemic. The pandemic seems to have taken everybody by storm, and let us say it's a nightmare more than a storm. So like COVID-19, PCOS is on the rise like a pandemic, and it is the disease of the present generation. So if I were to take that analogy further, I'm more worried about India. We just managed to become the second highest country with the incidence of cases. That is no honor we would like to talk about. But what is more crucial is also to see that there's another silent pandemic that is happening to close to every third woman in India. From 2007, when we thought it was 1 in 15 women, we suddenly seem to have increased almost 3 to 5-fold the amount of women who have polycystic ovary. Now, here's an interesting piece of data. Generally, I don't go into demographics, but it would be useful to know that the population in the world seems to be wavering up to about 20% or slightly more than 20% with the prevalence of PCOS. Apparently, a clinical trial was run by the Indian Journal of Endocrinology in 2012, which found that a pan-India, rural and urban, seem to have shown just about 3.7%, so slightly less than 4% chances of PCOS in an 18 to 25 age group. What was shocking was that when they ran a similar kind of a thing in Mumbai, they found the incidence to have increased almost 5-fold. Clearly, Mumbai is a city, and if we look at it as a city, does the city kind of living, or shall we say the lifestyle of a city, which we have long forgotten because 5 months we've been out of that lifestyle, contributing to this pandemic? And therefore, I thought it would be appropriate to start at the beginning. So, polycystic ovary, is it one disorder? Is it the ovary only? Or is it a collection of system malfunctions with the ovary as a major component? We seem to have now concluded that yes, most likely it is actually a multiple set of disorders, more like a metabolic syndrome, which seems to have an ovary as its central component. So to put it in its perspective, it would be appropriate, as I said, to look at it as a metabolic syndrome with reproductive implications. What is important for us to understand that there's a huge impact, not just on the metabolic health of a woman, but on her cardiovascular health. For a girl, it can mean a lot of physical deformities, something which she's particular about, she would want to be particular about. And I think we should also look at this before we go forward to only looking at fertility. It, in brief, would be called the thief of womanhood. So here's a small graphic which sort of sums it up. If I were to look at the three major components which are by now made famous by the Rotterdam criteria, you should visualize your ovaries to be polycystic is one of the criteria. You have to look for signs of hyperandrogenism and irregular periods. Now, why have I gone in this order? For the simple reason that most times we tend to look at polycystic ovary when a sonographer sends us a report saying their ovaries look polycystic. What you should be looking at is clearly what she comes to you with. Signs of hyperandrogenism and of irregular periods is something you elicit out of the history. So clearly we should have our priorities right, especially when we look at irregular periods. Now, these irregular periods, let me clarify for the sake of everyone who's on board, what are we looking at? So, as we said, there are those famous criteria, 2 out of 3 will give me signs to suggest Rotterdam criteria, but let's break this down for our understanding. So, let's say for simple things like signs and symptoms, how soon can they begin? They can begin almost at the first period or may take a little longer. Now, this is important because initially the woman or the girl may not give you a history of irregularity, but irregularity sets in later with weight gain. So be particular to look out for this particular thing, where she suddenly started putting on weight and then she started noticing signs of irregularity. Similarly, if I were to just look at the menstrual abnormality that a girl faces, she may come up with something very innocuous saying that there's just a 35-day cycle instead of a normal 28 or a 30-day cycle. Even that should let the alarm bells ring. Or if you look at a history of about a year when she started her periods and you find less than 8 menstrual cycles, take that as a significant history. Similarly, even if you have 3 consecutive months where she's not bled after having had some regular periods, the alarm bell should be ringing. And last but not the least, if you notice the last part on my slide, it says prolonged periods, and you may also have both scanty and heavy periods. So sometimes one tends to ignore, because often enough as undergraduates and postgraduates, oligomenorrhea is drubbed into our brains. some girls may actually have excessive bleeding in a cycle. Now, along with that, you'll get some symptoms. And why am I taking time over this? Because it is important that we pick it up early. Like in a pandemic, they say various parameters have to be checked earlier on to see that we prevent long-term damage. Hirsutism for once. Now, most girls will be very sensitive to this issue. So anything like dark coarse hair, as you can see here, especially if you look at her face and ask for a history, whether it's also present on her face, neck, arms, or when you examine her also between her legs, you will be able to understand that this is a typical PCO representation of hyperandrogenism. So with the irregularity of periods, and if you look for signs of hyperandrogenism, your two criteria of 3 are already met. So you are going to be quicker in treating her, quicker off the blocks in trying to help her restore to health. Now, this is a common representation which also is seen, acne, for example. Now, what you have to understand is these are typically dirty looking acne which don't seem to go away with the normal precautions that a girl takes. This is because you have hyperandrogenism. And typically, you will also find these present on the jawline, the arms, and the chest. Now, this is very unusual, unlike the normal acne that you get to see with this age. Also, at this point, if possible, start to look at the possibility of what is called as a dirty neck. Also, again, similar things like pigmentation will be seen on the underarms. A very significant point which one tends to forget sometimes in the history is to ask for light sensitivity and some evidence of nausea and dizziness. This is quite often present. Migraines are quite often present at this age group. Now, what I'm trying to say is we are not looking at adolescent PCOS. We're just looking at early signs that can give us a quick clue. Clearly, if you had to look for signs of hyperandrogenism, you'd look for, let us say, acne, hirsutism. You will also tag it along with irregularities, and you can look for acanthosis, which I've just mentioned. Clitoromegaly may be checked. But it is important to understand, don't keep on pestering the girl asking for history of alopecia. Quite a few girls may not have alopecia at this age. And therefore, acanthosis and alopecia are both signs to suggest the severity of polycystic ovary in a girl, which means your actions should be accordingly calibrated for the girl to benefit from your treatment. So I come back to this graphic that I was talking of. We said it is a lot of things put together. Polycystic ovaries is what we wanted to diagnose. So clearly, if we have two of those, which are in yellow, hirsutism, which is an androgen excess and irregular periods, your criteria have already been met. But let us say if you are going to go a step further to look for polycystic ovaries on sonography, what are the precautions? The precautions would be clearly, this is what has been set, 12 or more follicles. Today, the criteria have been changed to even 10 or more follicles, each not exceeding 9 millimeters. Or you can even look for increased ovarian volume. So you must realize the criteria have actually been stretched to include many girls or women who may not find themselves in this category because treating it early is more or less treating it well. Then I come to this criteria, again in ultrasound, and I quickly thought I would put in this slide. Like I said, if you do it in the post-menstrual phase, you are more likely to see what is called as no dominant follicle or growing follicle, so your volume measurements don't go wrong. You must also be aware that you should simultaneously do a transabdominal sonography if you find signs of hyperandrogenism, because sometimes one tends to have what is called as androgen secreting tumors, which may actually mimic polycystic ovary. If I had to send her for laboratory investigations, most of them are driven towards finding signs of hyperandrogenism. So you would typically do a total testosterone, look at free testosterone, which is a little difficult unless done properly. You can look for serum 17-hydroxyprogesterone, and remember, try to take it early in the morning. If you have a normal value of DHEAS, it rules out more or less an adrenal or an androgen producing tumor. Most people will advise a SHBG level at this point of time. Now, along with that, it is important to also look at the possibility of her thyroid status, which is the second most common endocrinopathy, which we see in this group, and look for hyperprolactinemia. So this sort of rounds out what you've been looking for. So like I said, I come back to the famous Rotterdam criteria. Any two of these three, the first one being an imaging modality, the second one is a very diligent and a strict history, and hyperandrogenism, which is what you see, and she reiterates, the patient reiterates when you ask her. So clearly, you need not require the lab backup to confirm polycystic ovary. Two of these three are good enough. So I won't waste time, but hit on straight to the next part of my discussion. So what are we looking at? Obesity seems to be running very commonly along with this. So I thought it would be appropriate I quickly look at this. What is interesting is to note that the obesity amplifies the severity of PCOS and increases the metabolic dysfunction. Clearly, a obese PCOS might just benefit from simple correction of the obesity factor rather than make a huge and fervent attempt to give her drugs which may or may not necessarily work if given independently. So you will have to combine lifestyle modifications. Here's a very interesting slide I put across. This is because the JAPI in 2009 clarified that the normal BMI for an Indian girl could be below 23 kilogram per meter square, which is how you calculate obesity. Now, between 23 and less than 25 is called overweight in India. Anything exceeding 25 would be called obese for an Indian girl. Now, if you see the criteria for the Western population, which is at the bottom of your slide, you will see that a BMI exceeding 25 is just considered overweight. So technically what I'm trying to say is an overweight Western or a Caucasian girl may actually be considered obese in the Indian context. You must also know there seems to be some kind of a geographical distribution and separation here. For example, the more affluent states like Punjab, Kerala, and Goa seem to have a higher incidence. Now, this is data that was gleaned out of the National Family Health Survey in 2007. And the slightly less urbanized states like Jharkhand, Tripura, and Telangana had less of it. So there seems to be a connection between the lifestyles of urbanization and the prevalence of PCOS, which means it can be controlled if we were to go back to a slight lifestyle modification. Now, finally, do not forget the last line on the slide, which says obesity amplifies the severity of PCOS. And at any point of time that she is, whether she's demanding fertility, whether she's demanding just good health, or avoiding complications like diabetes or heart-related issues, it would be good to look at obesity in that light and help her lose that obesity so that the effective treatment is delivered by that. Now, just to take this a little further, what you have to understand is a weight loss of just 5 to 10%. So for argument's sake, if you have somebody who is just 70 kilos of weight, a drop by 3.5 kilos minimum in a physiological or in a guided manner by a dietetics expert can actually dramatically change the outcome. In 2018, ESHRE introduced a smart set of guidelines. The SMART strategy, apart from being a very smart acronym, actually means something. The S stands for specific, M is for measurable, A is achievable. I found A very interesting. If you start counseling the patient, it is A that you need to stress on, and then take it to the next level by saying it's realistic. And finally, give her a time frame in which to work. This is a very nice way to put out a way for her to take it forward. Now, having said that, the 2018 PCOS management guidelines seem to have nailed it on the head by saying weight loss, exercise, and lifestyle modifications, which have a synergistic effect, basically can even restore her not just to health, which may be just metabolic health, but it restores her even to her reproductive health, which is very interesting. And finally, morbidly obese women, even if they were to plan for a pregnancy, should seek advice and get counseled about whether they actually stand a higher risk because of pregnancy. So I think I have covered this part of it deliberately a little slowly. I wanted one of the ideals or the aims of our treatment. The first aim, I think, when a girl comes to you, may be that she wants to regulate her menses. It is also possible she may come to you by saying that right now fertility is not important to me, or that she wants to look at fertility a little later. So if it is only regulation of menses that you have to look at, you have to also tie that up with improvement in her androgenic concerns, which means you can regulate it by giving her a simple oral contraceptive pill. But along with that, if you can improve her androgenic concerns, I think you will be helping her tremendously have what is called as good body image, which is one of the issues which these girls have. Finally, if you can also help her improve her metabolic status, that would be outstanding, which means you're restoring her to health. So as far as we are concerned, if we were to offer her drugs, the drug should purpose try to meet these three criteria which we have set as ideals for our treatment. And finally, if we can prevent her from getting any comorbidities or prevent comorbidities because of the drug itself, we would have achieved our target. So let me just sum this up. If I were to say you wanted to regulate her cycle, the normal cycling woman is likely to be psychologically much more relaxed. Anyway, a polycystic ovary girl tends to be anxious. So somebody who is not anxious just because a cycle got regulated has actually benefited indirectly from your therapy. If I mention or take it further, by decreasing her hyperandrogenic state, her appearance, especially the skin, the hair, the face, tremendously changes her outlook to life. Finally, improving the metabolic parameters and preventing lipid profile derangements, as I mentioned, is one of the criteria for our drugs. And finally, assisting in her weight loss would be an added benefit. So imagine a therapy which can achieve all three and might even assist her in the weight loss as a bonus. So what are we talking of? First of all, let me highlight the fact that this therapy is more or less like the control of PCOS. This is not the treatment for PCOS. For that matter, you have to live with this disease lifelong. But if fertility gets added on, only then you have to look at actually changing the paradigm. So if I had to just sort of control or manage, as I said, my PCOS, suppose, as I said, you had to treat hyperandrogenism, and if you wanted to technically even protect the endometrium of, say, an elderly PCOS from going into hyperplasia, which is one of the requirements for a woman, you can offer her what is called as an oral contraceptive. Now, I think the oral contraceptive has been the most researched drug in the history of mankind. It has a lot of various additions and subtractions that have been done, and it has arrived at its own evolution. So clearly, one drug which is good for preventing a pregnancy can always be used for this. Does it work like that? Apparently, yes. The only question really that we need to talk is what kind of progesterone should we use for a girl who has typically PCOS and is going to take, let's say, treatment or medical treatment. A little further along, I'll be discussing that. So if I were to look at contraceptives, like I said, I would just be worried or thinking of which progestin. But let us say we didn't do that and we wanted to treat her for only her hyperandrogenism. We have various options that may come. What could they be? They have been listed here: flutamide, finasteride, glucocorticoids. I've deliberately put insulin lowering agents a little lower down, and then other methods. So this is like a holistic approach to getting her body image to normal. However, what is very interesting to note is that oral contraceptive with the addition of cyproterone acetate has found to have been the most effective drug therapy for a patient of PCOS. So let me start with cycle regularization. Suppose a girl had 88-day or a very irregular cycle. If you wanted her to become a normal cycling girl, you could bring her to a 28-day cycle, as much with a cyproterone acetate with ethinyl estradiol, and that cycle may stay restored for a slightly longer period of time, even after you have taken the drug away. So this is the interesting part, that even if you were to give this for a short course, you may have 1 or 2 cycles following it when you've stopped it, when she might be regular. Now, here's a very interesting chart that I thought I'd put across to you. Suppose you look at the effect of cyproterone acetate and ethinyl estradiol, and now you start looking at 3 dosage of ethinyl estradiol that you can give. There's something very interesting that was brought to the notice. If your dosage for ethinyl estradiol was just 20 micrograms, and you use 3 milligram of drosperinone, which means more or less your low dose contraceptive pill, your chances of increasing the possibility of, let us say, the hormonal parameters or the improvement would reach an average increase of about 85. Whereas if you just slightly increase the dose of ethinyl estradiol to 35 micrograms and added cyproterone acetate of just 2 milligrams, which means it is a specific drug for polycystic ovaries, you found that an average increase dramatically changes, which means not only do we need to slightly increase the dose of ethinyl estradiol, but as this graphic shows you, a standard pill with either desogestrel or drosperinone as the progesterone of 0.3 ethinyl estradiol compares not so favorably with ethinyl estradiol and cyproterone acetate in the dosage of 0.035 milligrams and cyproterone acetate of 2 milligrams. So it was a very interesting finding because the SHBG levels went up very fast, which is one of the parameters. Now, this is another interesting parameter that came up in the similar study, which shows that the amount of circulating free testosterone, which is more or less the culprit, seems to have come down best with this combination of 0.035 of ethinyl estradiol and cyproterone acetate of 2 milligram. So this is a nice comparison to understand which works better. It's not that the oral contraceptives do not work, but there may be something better which is available. And finally, the free androgen index, which also seems to have benefited because of the presence of ethinyl estradiol in a slightly higher dose along with cyproterone acetate. So basically, if you had to check the combined oral contraceptives and the biochemical parameters and signs of hyperandrogenism, a systematic meta-analysis was done by Meena Amiri and her group, which found that basically all COCs had similar effect on the hormonal profiles. It's not that one doesn't do anything at all, but CPS seems to have a little bit of an edge, especially when there is hirsutism. So here's a take-home message, the first one, which says that if you had to choose for other things like hyperandrogenism or for hirsutism, you might go more in favor of, rather than oral contraceptives, something that may be more effective. And finally, cyproterone acetate, its safety was one factor which came up for discussion. By increasing the dose by 5 micrograms from 30, there doesn't seem to be a huge risk which we are incurring as far as venous thromboembolism is concerned. The absolute risk also stays low, and you must understand that the net benefit of a shorter course or shorter duration of treatment might be better than offering the drug or an oral contraceptive for a longer period of time. So clearly, there are practical benefits of this combination of cyproterone acetate with ethinyl estradiol. And what is more important is, if you see the last line on this slide, the European Journal of Contraception and Reproductive Health 2017 seems to have mentioned that even in pre-treatment towards fertility, which is what we should be bothered about as infertility specialists, there seems to be a dramatically different improvement which you see compared to pills. Now, I'm not going to recommend this to every woman who undergoes it, especially the one who are poor responders, but this can be used to sort of stabilize the metabolic status and get a better outcome. Talking of which, I thought it would be best to summarize what I have been just mentioning. If you were to administer a contraceptive, beware of the fact that you will have to give it for a long term, something like 4 years, 48 cycles. Now, this is one thing you will have to clearly explain to the patient. There is a social amount, a certain amount of social criteria that one has to use, a social taboo that may be attached to an oral contraceptive pill, which a girl consumes for a long period of time. And therefore, giving a prescription medication drug may also be useful. What they found was the acne resolved within the first 2 years dramatically, or at least converted the hirsutism from mild to maybe almost resolved, or sometimes from moderate to mild, which is more treatable with other measures. So basically, you can't change the whole picture by giving a drug. You will have to have additional therapies. But it is interesting to note that this one drug seems to have been something that seems to be the backbone of treatment if it is not to be involved with it, to be involved with only fertility. Now, finally, a new definition was suggested in the Lancet, which means they are talking of it more like a metabolic syndrome. Technically, what it means is there are a lot of endocrinologists and physicians and cosmetic surgeons and cosmetologists who will jump on the bandwagon of PCOS, and generally, as gynecologists, will be sidelined. So you had better be smart to this and be able to talk convincingly to them. Therefore, I thought it would be appropriate to just look at this PCOS iceberg. Infertility and hirsutism may be some of the presenting symptoms for this girl, but her cardiometabolic risk is something that you should be worried about. And that is why a multidisciplinary approach involving not just maybe an endocrinologist or a physician, but a dietetics expert, a lifestyle guru, as they call, can actually help you heal and cure this girl better. So, having talked about that, I thought I would not waste time and straight jump into what is called as insulin resistance, which seems to have been something commonly seen in close to 70% of the women. Now, let me just jump into something where we are looking at the pathophysiology of this hyperandrogenism. So, we know for a fact, how are these two linked? Now, insulin resistance means more insulin gets secreted by the body to compensate for its inability to do the job that it was able to do previously. That itself can actually increase the GnRH pulses and increase the LH. This increases the androgen production. So at one end, you have an entire cascade that is set into motion with insulin resistance. Logically, if you can correct it, you may even find an improvement in her androgen or hyperandrogenic state. Precisely how I would like to put this by a small explanatory graph or an explanatory slide here. Let's assume in a normal cell wall, the insulin receptor binds to its receptor, which is in yellow, that enters inside the cell or opens the door, as they say. When that happens, there's an enzyme called PI3 kinase, which activates the glucose transporter 4 to get glucose in. For a cell to survive and do its job properly, it needs glucose. For that, it will need the glucose transporter to work. And therefore, it is important for us to understand a very fundamental cellular level molecular biology fact. It is that PI3 kinase, phosphatidylinositol 3 kinase enzyme is required. Now, as we go along, I'll be alluding to this as we go. Now, let me go back to this whole thing about insulin resistance in the progression. What really happens is it increases the production, as I mentioned. There is an oversynthesis directly by the ovary of androstenedione and testosterone, which makes what is called as a ovary which is predominantly androgenic. This makes it what is called as a non-working or a differently working or a differently abled ovary. So we must understand that whenever we look at a fertility problem, you have to try to set right this androgen excess ovary to its normal metabolism. Finally, you must also understand that the fact that we talk of 30% of the girls which I talked of may not actually have obvious obesity. But the obesity in these lean PCOS is actually what is called as android obesity. It may be deposited not in the abdominal wall, but in the visceral peritoneum. Now, if that is the case, that is the one which gets mobilized or metabolically the most active. So these girls also need correction with insulin sensitizers. It is a misnomer to think that an thin PCOS does not need insulin sensitizer. Basically, once you understand this part, and that the added other factors can be corrected, we should now look at hyperinsulinemia, which is basically a situation which we caused because her body reacted differently. Hyperandrogenism further exacerbated it. Now, we must understand for her the quality of her life, which may not necessarily just mean reproductive health. We will have to take her out of this hyperandrogenic state, this hyperinsulinemic state, which means make the insulin resistance less. Technically, this is just for all of us to understand that just doing a fasting insulin may not be the right parameter because it can be misleading at times, especially if it is not done on an empty stomach. So what is suggested is the HOMA index. I won't go into that detail. One point I want to highlight here is inositol clearance. And this is interesting because I'm dropping facts as I go along for you to pick them up and string them together later. Inositol clearance levels in PCOS and normal women are different, which means fundamentally something may be genetically wrong with her, or her kidneys are listening to a different command in a PCOS girl, where actually the clearance of her inositol is higher and the resorption back is not happening as it should in a normal woman. So this is one factor you cannot forget. So what are my options? If I were to offer therapy options, the basic thing that you should understand is you would give her what is called as insulin sensitizers. Now, if I were to give her insulin sensitizer, the first molecule that jumps to mind, thanks to the endocrinologist using metformin, I mean, they use metformin right, left, and center. So here you have metformin stimulates PI3 kinase, and therefore you will have the mechanism working fine. So metformin seems to be the obvious choice. Where is our problem? Please remember, I told you in a polycystic ovary patient, the clearance of PI3 kinase is much higher. Inositol is much higher. So because of this, the PI3 kinase itself available in a cell may be low. So metformin will work provided we do not have depleted stores of PI3 kinase. So the mechanism and the action being so, anywhere between 500 to 850 milligrams of this drug was suggested, generally well tolerated. You have to titrate it to prevent reactions, if any, in the form of, let us say, some amount of acidity or hyperacidity, which a girl may notice. What is very interesting is the fourth line on this slide, which says, it may actually help her or assist her in weight reduction. Now, this is interesting. This was seen in the light of various other benefits it may have. So clearly, this was the first kid on the block. You can slightly increase the dose. The problem is its Tmax value is reached very fast. So therefore, you may have side effects related to the escalation or increase in the increment of this. So the question really is, should we continue metformin therapy over a period of time? It has definitely shown benefits in a lot of other things. Unfortunately, the data today doesn't seem to support its continuous use for only fertility purposes. So people often ask us, can we combine the two therapies? Can we combine metformin as a girl goes on in life if she has a PCOS? Yes, the honest answer is yes. And here's validation of that fact. Endocrine and metabolic effects of metformin alone versus giving her this pill that we mentioned, a randomized study was done, which was very interesting. It seems to have a very synergistic effect or similar effect. So the million-dollar question really is, will both of them help? Maybe, but I think you should involve an endocrinologist before you start planning for long-term use of metformin. Similarly, metformin may also have certain other benefits, like the waist-hip ratio may change, the serum testosterone may actually drop faster, and therefore, I think a synergistic effect can be used. So one of the take-home messages today is that we have reached the era where we can try to combine two therapies if possible to quickly accelerate the benefit from either one of them. Now, I finally come to the role of PI3 kinase again, and I'm talking of a new drug which came on the block around 2011 and set the whole world on fire. Simply because myoinositol was something which was actually supposed to help in the activation of PI3 kinase. So one of the thought processes was, can we look at the possibility of giving only myoinositol to these girls and see if we can improve it? Now, a lot of water has flown under the bridge from 2011 to now, including a new pandemic that we are battling. Inositol was basically what seems to be the basic cogener, as we call it, of myoinositol. So inositol is a chemical compound, and it exists in about 9 different forms in a human body. These are called as isomers. The two most prominent are myoinositol and dechiroinositol. So the logic is that if you can administer these myoinositol isomers, you may actually treat these girls almost like a deficiency state which needs improvement. So here's the data that seems to have been shown, which I have talked of earlier, in PCOS subject, the plasma inositol clearance was grossly more than at other times. And therefore, when they actually compared, this was one of the early studies where they found that the insulin action was improved far better when myoinositol, especially when it was combined with folic acid, as compared to metformin. We're talking of only insulin action here, which means one of the two insulin sensitizers seem to have a slight difference in their effectiveness. So have we arrived at the ultimate insulin sensitizer? Is myoinositol it? This is what we felt at around 2012 and 2013. Unfortunately, it controlled hyperinsulinemia dramatically. It increased SHBG levels. It also helped in controlling hyperandrogenism. But its peripheral effect didn't seem to be so much. It also brought around good hormonal regularity to a girl who probably was interested in her fertility. So a new thought process came into play, which says if we combine the two synergistically, myoinositol and dechiroinositol, which we always knew, will it help? Logically, what really happened was, as they say, history by 2014, where they said that they took the two drugs together, or the two isomers together, put them together. And what they found was, they actually found that the drug was far better, especially in very obese or grossly obese girls. So if you tried your lifestyle modification, if you looked at weight reduction and nothing was helping, if
Sir, sorry to disturb you. Sir, there's only 1 minute left.
Yes, I'll finish now. So I'm about to finish now. So basically, inositol and myoinositol were combined, and the dechiroinositol and myoinositol were combined, and especially in obese girls, it was found to have both the peripheral action, which was because of dechiroinositol, and myoinositol, which worked to achieve ovulation. So I think we have arrived at a situation where, as we go along into the path of treating a patient of PCOS, we are looking at how to improve the chances of her being restored to health as well as fertility. I have touched upon it. Today does not allow me to go into the fertility aspects of it. But suffice it to say, because it was 40:1 ratio that they found in myoinositol dechiroinositol combination in the plasma, what do we know about PCOS today? A lot more than we knew yesterday. And clearly, the way to look forward is new developments seem to be occurring. And as they say, these emperor penguins sit together to discuss about the future of the world. We sit in our small cocooned world, looking at the possibility of having a discussion with therapy options. Ladies and gentlemen, if I were to put the therapy options clearly to you, you have to break this girl out of a self-perpetuating vicious cycle, bring down her tonic levels of LH if possible, take away the excess androgen, and if possible, help her for achieving ovulation, which is a topic for another day. And therefore, you have to finally take the three things that are important. The first step is to help the patient understand that this is a chronic disease process, controlled and changed dramatically with lifestyle. Lifestyle modifications have to be emphasized. Medicines may just complement the impact, and therefore ovulatory agents should be added on top of this. I take this opportunity, ladies and gentlemen, to thank you for patiently listening to me and just highlighting the point that if you are looking at fertility, do not waste time with simpler measures if any of these below documented factors are present. I appreciate the time that has been given to me, and thanks Senora for inviting me onto this summit. And I hope we do get to interact all the more again, if possible, to discuss this topic in detail. Thank you for reminding me of the time, Rohan. I appreciate it. I hope I have kept it this time.
Thank you so much, sir. It was a really wonderful talk, and we would like to go ahead with our next session. I will just introduce
Yes.
Dr. Vidya. Can you see the screen?
Yes, ma'am.
Yeah. So Dr. Vidya Pancholia. Dr. Vidya Pancholia, she's a senior obstetrician and gynecologist of Indore. She has done her master's course in aesthetic gynecology and super specialty and gynecological laser. She is editor of Foxy Connect 2018, editor of Practical Obstetrics Committee Journal, and souvenir of IMSCon ISAR IOGS newsletters for last 10 years. She has represented India at international platforms like RCOG, AOFOG, FIGO, and IMS. She has been awarded fellowships of Indian College of Obstetrics and Gynecology. She has been awarded Women Excellence Award in 2018 and Nari Shakti Award in 2017 for the social cause. She has co-authored books of professional interest and published articles in Index Journal. She is running a high-risk pregnancy center and Guard Yourself clinic. She is life member of Foxy and many other societies. She has been faculty in several national and international conferences. Today, Dr. Vidya Pancholia will be enlightening and talking on the topic of energy-based devices and their role in optimal feminine wellness. I welcome you, Dr. Vidya, madam.
Very much for the nice introduction, and I will like to ask a question that how much time is left. With that.
Yeah, ma'am, you have a 20-minute time for the talk now.
Okay, fine. So I am going to share my screen. Can you see my slides?
Yes, ma'am, we can.
Okay. So, dear friends, vaginal laxity.
Doctor, sorry, kindly unmute your camera. Start your video.
Yes, yes. Can you see my slides?
Yes, we can see your slides, but video not appearing. I mean, kindly start your video.
Okay.
Yes, please go ahead.
But I request that I will in between stop my video. Only slides will be seen. Okay.
Yes, ma'am.
Okay. Okay. So today I'm very, very thankful to Sonora, Dr. Rohan, and all the team members to give me this opportunity to talk on a very, very nascent subject, and that is the energy-based devices and their role in optimal feminine wellness. There is some network problem. Just give me a 1 minute time. Now, can you see my slides again?
Yes, doctor.
Yes. So what I was talking that we are going to talk on the energy-based device, and as we all know, this is a nascent subject to talk on this topic, and we all are agree that vaginal laxity, stress urinary incontinence, vaginal atrophy and urogenital syndrome of menopause has subordinated our women since ages and never had any concrete medical solution. So today we are here to address this problematic situation with a very patient-friendly, doctor-friendly modality. The body of evidence about management of pelvic floor disorder continues to grow in a newly board-certified subspecialty called female pelvic medicine and reconstructive surgery. These are the common problems of pelvic floor dysfunction, and we are having these type of patient in abundance in our OPDs. Pelvic floor disorders can affect the physical, psychological, social, and lifestyle restriction is very, very commonly seen with these patients. These are the standard surgical procedures we are doing. So if there is a severe compartmental defect, if there is a big tear in the ligaments and supports, muscle supports, then we have to opt for these type of procedures. But there is one more condition called vaginal relaxation syndrome, and that is the result of physiological changes due to pregnancy and childbirth, hormonal changes due to aging and menopause, and weight fluctuation. And as a result of that, there becomes a roomy vagina, and then the patient and her husband, they refers VRS as loose vagina, and that is going to give a great impact on their quality of life. This type of relaxation is there. And there are a lot of studies from the pioneers of sex medicines that because of this roomy vagina, there is a poor sexual gratification. The another thing that takes place due to VRS is stress urinary incontinence. And you can see the darker blue bar, that incontinence is more prevalent and commonly seen in these women of middle age group. And we are hardly bothered about the most prevalent phenomena that is taking place in their body. And if we see the age-wise prevalence, it may start from very early age of 20s, 30s, and the bar goes on increasing. And by the age of 80 to 90, more than 90% of women start suffering due to SUI and type of incontinences. And we gynecologists, we are always talking about the fibroids and APH and PPH and whatnot, infertility, but we are actually sidelining these type of most prevalent problem of women. So I think we should think again to address these most common problems of women. So it is the hypermobility of urethra, and MASH complications are very, very high, which what we were offering in past. And we also know that these MASHes, the learning curve of a gynecologist is very, very long to provide these TVTs and all. And the mass people, like the mass population of menopausal women, everybody cannot go with the MASHes, and MASH complications are very, very high. They are getting of SUI, but they are landing into overactive bladder. The next thing that happens due to this VRS and menopause is the postmenopausal GSM. Very, very common problem. And as a gynecologist, we are treating them, giving them antibiotic, symptomatic treatment for dryness, the lubricants. But do you think they are happy with you? I will say no, because their pH is changed. Because of they are having recurrent problem of infection from vagina, urethra. And if we give them estrogen cream, the vascularity is so poor that these creams are not going to help these women. So again, I want to tell you that we should indulge in this type of modality, which can make our women more comfortable and we can improve the quality of life. So the previous treatment, what we are having till today is the vaginoplasty, pelvic reconstruction, labiaplasty, HRT, and topical hormones. Now there is a big buzz all over India about the energy-based devices. Now new trends is gaining momentum in the advent of energy-based device that apply thermal and non-thermal energy to the various level of vaginal tissue. And these devices, they claim that they induces collagen contraction, neocollagenesis, growth factor infiltration, revitalizes, restores elasticity, and moisturizes the vaginal canal. This is an exhaustive list of energy-based devices that are available in the Indian market. But dear friends, I just want to convey one important statement from me, that all energy-based devices are not same, though you may see the same type of indications, but they are totally different. And we will see one by one in few lines of about every device. One, you may have heard about the radio frequency. Thermiva is commonly used, but I will say that it is the safest one. And it actually emits the focused electromagnetic waves. It is used in vaginal tightening, used in betterment of contouring of vulva. But if a question comes about the laxity and SUI, it is so light, and its thermostat is so weak that it cannot maintain a particular type of thermal energy inside the vagina, and the disposable wand is very, very expensive for our in our Indian scenario, and we cannot reuse this wand. So if somebody is reusing it, it is totally wrong, because there is no way to sterilize these wands. CO2 lasers, if your patient is very young, I will agree for that, because it works, or it is a laser, and radio frequency is not the laser. So CO2 laser causes microablations into the vaginal canal. So if your patient is very young, it may be very effective, because there is so many good collagen is also there in the vagina, and they will heal the microablated area. But think or imagine your patient is very old, having already the atrophied vaginitis, caruncle, cuts, wounds. You cannot afford CO2 lasers in such type of patients. So you have to think twice to indulge in these appliances, and it should not be market driven. You should be properly trained. You should know the biophysics of lasers. HIFU, again, the same indication for vulval and vaginal rejuvenation. It is okay, but for SUI, again, it is a weak system. It cannot make temperature inside in a stable form to produce neocollagenesis. Now I am going to talk about the erbium YAG laser from Photona that I am using since almost now 4 years. And it is a completely non-ablative smooth mode lasers, and it results in non-ablative thermal diffusion. And I will say it is the safest. Any type of patient, young or old, GSM or SUI, it is the safest one. Now a little bit about the knowledge of lasers, as we gynecologists are not using lasers in day-to-day practice. So laser is a light has energy. Laser beams, they go into coherent direction, all goes into plateau and valleys, and they can be focused to some point where we want to deliver the energy. And what are the electrons and photons and how the lasers are produced? Just one slide to show you that electron remains in the resting phase, and when it is stimulated, they produce photon full of energy and they make a wave. Then what is the thing that decide about the name of laser? If it is a gas, then it is CO2. If it is solid, then it is alexandrite, ERA, and so on. Now, what is the effect of lasers? It is the photostimulation, photodynamic reaction, and photothermolytic action that takes place after lasers. Now, what is chromophore? Chromophore are the substance which absorb the laser beam. So, if you want to do something on the skin, then the melanin is the chromophore. So, you have to see the laser which can maximally absorb into CO2. If it is a vascularity, if you want to do some surgeries into vascularity, you have to see that your laser should absorb in hemoglobin. So melanin in the skin is the chromophore, hemoglobin is the chromosome in the vascularity, but if it comes to the vagina, then your chromophore is water. So it causes increment of fibroblastic activity. There is a release of cytokines and neocollagenesis when the thermal effect of laser is given to a particular tissue. Now, how it causes collagen contraction and neocollagenesis. This is very, very interesting that with only 5 degrees of temperature rise inside the vaginal wall, it actually stimulates the heat shock proteins that are already there into the vaginal tissues, and with the transforming growth factor. This is a particular enzymatic reaction, chemical reaction that forms a new collagen. There is nothing like burn or charring inside the vagina. It works simply on a smooth thermal diffusion. And this is the slide, dear friends. I want to tell you that the temperature what we want inside the vagina is only 50 to 60 degree. Whatsoever amount the time you are giving inside the vagina, but cutoff point is 50 to 60 degree. That causes reversible collagenous protein formation. And anything that gives more temperature, like to give a coagulative effect, can be harsh to the tissues. So there is a typical tissue reaction. By 30 to 40 days, we have complete remodeling. We have mature collagen fibers. As you must be knowing that our Asian women, they are having very poor collagen type. Because of that, we are seeing so much prolapses and cystocele and all type of uterocervical descent and problems of urinary control. So it causes formation of better collagen, that is the collagen type 1. It increases the collagen fiber strength. New vascularization can be clearly seen, and it is leading into improved lubrication and pH. And because of that, you can offer these type of fractional lasers from outside the vulval canal to a very young patient who is coming to you for recurrent vulvovaginal infection, because glycogen is depleted, pH is changed, they are having acidic pH in the vulval canal. So whatever amount of antibiotic or antifungal you're giving, they are not going to be happy. So these are the indications for erbium YAG. What I am using works on the non-ablative mode. And if you compare with the carbon dioxide lasers, commonly we are having family in India working. Their network is very, very good, and many doctors are purchasing CO2. But you have to decide, dear friends, that what type of patients you are having. If they are more for tightening and young patients are there, you can very well go for CO2. But if you are having a big chunk of old patient, then CO2 laser may be a little bit harsher. This is the magic of IVM Smooth. After 6 months, you can see a significant thickening of vaginal wall. You can see the slide D. And laser used in modern medicine is 100% safe. Many of the initial stage of my launch of this machine, many gynecologists were saying, Vidya Didi, se koi burn to nahi ho jayega. So it is not working on ablative mode, and that's why it is so safe. Now we can see the neocollagenesis after 6 months. You can see the neovascularization, the collagen, the newer epithelium, which are remodeling is done after 6 months. This is the biopsies or histopathology. The post laser treatment, the things are wonderfully changed, and there are lot of evidences in the MRI about the vaginal thickening. UV angle also changed, so the SUI patients are very happy. Now, Intimalaze is for the vaginal tightening, for the sexual issue, but they all modes are in one machine, and we have to just change the programming what we want to do on the machine. So Intimalaze is for vaginal tightening, and it's the same way incision lace non-ablative for photothermal tightening. The thermal powers can be adjusted from the robotic arm. Incontinence is for the urinary incontinence, and it is embedded in the same machine, and programming can be done. Now you can see how cumbersome is TVTs and the complications and the overactive bladder, and how friendly is this type of device where we are giving thermal diffusion to the anterior vaginal wall, and definitely after thickening, the UV angle will be again formed. This is something, the fractional Renovales therapy for GSM. If there is the various sizes of speculum that are there, but if she's not very comfortable in the speculum, you can give a small one therapy from outside the vulva. And dear friends, after say 1 month when she comes happily, because her caruncle, cuts, wound, everything gets healed after 40 days. Now, this was in future, but I am very happy to share that this device is also with my laser machine, because many of the patients, they say that when they are sitting, they are not continent, but as soon as they stand up from the bed or the seat or anything, then they leak urine. This is because of intraurethral this deficiency. So we are having this device to address those type of patients. So this is the robotic arm. It is wonderful because it is giving accurate laser delivery, fully automatic, easy to operate, increase patient compliance and shorter treatment time, because we are very, very busy with other works also. So we want a device which can work for at least 10 to 15 days, a minute, and that's it. Lot of clinical trials are going on, and these are the big names of our laser world who has contributed more than 20 years to make it safe and to convince the whole world that yes, they are working. And the Guamiras, Rivieras, Fistonic, these all studies concludes that the SUI is decreased, vaginal wall is thickened, there is a definite vaginal tightening. And this is the most elaborate study by Sarkaglu, where they are using perineometric measurement also, and all type of parameters, questionnaires, they are there. So in conclusion, the treatment protocol is promising. Therapy proved to be well tolerated. This novelty in the treatment presents significantly reduced cost because we can offer to so many patients. Few slides on my own experience with the Erbium. This is our dedicated laser center where we are only doing work, and there are a lot of satisfied patients with us. We are maintaining King Health Questionnaire, urinary inventory, and so many protocols, perineometry, and we are actually recording each of our patients before, after one therapy, two therapy, and final third therapy, 6 months and 1 year follow-up. So we are calculating all the these data and coming to the conclusion. And this is the how we are calculating the scores. For tightening, we are having questionnaire for female sexual function and dysfunction also, and we are following those international criteria to see the effect of lasers. Renoalase is for this urogenital syndrome, and these patients are, dear friends, are suffering from SUI. They are suffering from vaginal laxity as well as dryness, and they are suffering from this, apart from urinary system, they are suffering from prolapses, the uterocervical descents, and there are so many hysterectomized patients who are observing a bulge after hysterectomy. So the cystocele, rectocele, everything is there. So we are maintaining lot of data of these patients where we are seeing for incontinence, and then for laxity, we are taking visual analog by Bachman Vaginal Health Index. This is very, very simple. We are having perineometry also to see, and we are doing POP quantum also and scoring our result. Now, dear friends, this is not related to lasers, but you must be thinking that if collagen is improved, what about the muscles? They are so weak. These patients are not able to do properly the Kegel exercise that is really indicated to these patients. So it is a programmed Kegel exerciser, and if we give therapy of Kegel exercising plus lasers, then the results are terrifically improved. And this is the initial result of our study. And you can see a patient with three sitting, the satisfaction rate of is 80%. But in the second line, you can see a patient who are having incontinence therapy with chair sitting, then the satisfaction rate is 98%. This is the result of 30 patients having 2 follow-ups, and you can see the King's Health Questionnaire is remarkably improved, 94.3% in second follow-up. Now, for the Renoalase therapy, one patient with 3 sittings, 70% was a satisfaction rate after 3 sittings. And you can see there is improvement in the vaginal health index. Intimales also, they are the younger patient who come for the sexual issues. So after sitting, almost in all patients, 90% is the satisfaction rate. You can see in this graph that all interviewed patients were very, very satisfied after the third sitting, almost 100%. So this is the indications where we can use our lasers in our gynec practice, mild to moderate uterocervical descent. You cannot operate each and every woman, and the functionality will not improve. That is the thing I want to convey through this lecture. Cystocele, wall prolapse, SUI, recurrent vulvovaginal problem of menopausal women and young women, vaginal tightening, UGS. If we keep the mode of lasers from smooth into turbo is the surgical mode or aggressive mode, then we can operate on cervical erosions, polyps, cryouresis vulvi, lichen. It is ultimate to see the patient of lichen, how much amount of improvement you can see, and they are never satisfied by any of the gynec treatment, and suffering in the chronic, they become chronic and suffer in silence because of the matting of all genital parts, and sometimes their urethra also goes into that matting, and then it causes big problem to them. There are a lot of testimonial. We are giving trainings also, and we are really very happy to help these women. Thank you very much for your patience hearing.
Thank you so much, Vidya ma'am, for such a vibrant talk on the aesthetics and everything. Now we would like to move ahead with our next session. The next session is by Dr. Asha Bakshi. Dr. Asha Bakshi, she is Director, Disha Fertility and Surgical Center, Indore, and she's a senior consultant over there in association with Motherhood Hospital also. She is Joint Secretary of ISA 2020-21 of Governing Council of ICOG. She is Founder Chairperson, MP IAG and MP ISAR. She is Chairperson of FOGSI, Infertility Committee 2017 and 19, and also past president of IOGS. To her credit, she was first to go to ICA, first to do ICSI, TISA, ICSI and micro-TISA, for micro-TISA and TISA for the babies of MP. She is recipient of Dr. Kumud Tamaskar Award for FOGSI 2008 and 2009. She has a lot of awards on her name, and she has published a lot of papers in the Index Journal also. So, and also Dr. Asha Bakshi, she is a candidate for the Vice President elections of FOGSI from the West Zone. I request everyone to support her. I welcome Dr. Asha Bakshi, madam. She will be talking on abnormal uterine bleeding.
Thank you very much for the kind introduction. I'll just share my screen. एक मिनट share करना screen. Yeah. Very good afternoon. Thank you very much for giving me this opportunity, especially to the Sonora division of Sunpharma and to Dr. Rohan Palshetikar for making all the arrangements. And I bring greetings from Indore, which is the 4th time the cleanest city of India. And today I'm going to talk on abnormal uterine bleeding. And you all would agree that heavy menstrual bleeding has a major impact on women's quality, and it may be acute or chronic, and is defined as bleeding from uterine corpus that may be abnormal in irregularity, volume, frequency, duration, and occurs in absence of pregnancy. And we all are aware of this cyclical hormonal changes in the menstrual cycle and how does the menstruation occur. And the interval of the menstrual cycle may be 24 to 35 days. Duration is 4 to 6 days, and average amount is 35 ml. And it is the normal, these are the normal limits for uterine bleeding in mid-reproductive years. So if it is frequent, if it is less than 24 days, and it is irregular if more than 20 days variation, and it is prolonged if it is there for more than 8 days, and it is heavy if it is more than 80 milliliter. So these are all the definitions. The hypermenorrhea, when the duration is long and volume is more, then menometrorrhagia, oligomenorrhea, metrorrhagia, polymenorrhea, and intermenstrual bleed. So knowing all these patterns tells you something about the etiology also. Like menorrhagia is usually, if it is flooding, then maybe there is something like submucous fibroid or something like that. And if it is intermenstrual bleeding, then you are suspecting polyp. So a good history really tells you what's going on. And if the amount is too much, then patient may say that I've been having flooding, nal jaisa behta hai, or she may say I'm passing lots of clots. So these are subjective things. And I think most important is if it is affecting the quality of life. And prevalence is almost 20%. So it is quite high at some time or the other. A woman, almost 20% of women suffer from it. And most of the people have accepted this classification of AUB, because this is how you can really remember the etiology very well. And that is palm coin. So polyp, adenomyosis, leiomyoma, malignancy or hyperplasia, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, or not yet classified. And history is very important, as we have already suggested, whether it is associated with pain or not, whether it is cyclical or acyclic, what is the marital status, what is the sexual history, medications, and symptoms of pregnancy and reproductive tract diseases. And similarly, you have to check the woman for any other diseases, and especially the signs of pallor. And there are many tests available, and you don't have to do every test. I think you can tailor each test according to the patient's history, according to the physical examination. Laboratory test, I think it's very, very important to exclude the pregnancy, especially if you think this woman is sexually active. Then I think it's very important to exclude the pregnancy. And please check for the anemia. I think for our country, thyroid hormone is also very important, and the rest of the things. And then be vigilant to check for any signs of bleeding in the woman. There may be bruises, there may be petechiae, so that will also give you an idea. And imaging tests, there are many imaging tests that have been described, but I think for us gynecologists in our OPD, transvaginal sonography is a very, very good tool. And if then required, one can go for abdominal ultrasound. But just when the patient comes, you do a good per speculum examination, examine the right from urethra for urethral polyp, then vagina and cervix, and do a proper speculum examination to check for cervical polyp, which is bulging out of the external os. So that is really, really important. And besides that, in the clinic itself, if you have the ultrasound machine, you can do a transvaginal sonography. Before that, take a pap smear as well. And that will tell you a lot about the diagnosis, and immediately you would be able to help the woman. And tissue sampling is again important whenever it is indicated. And on transvaginal sonography, you may see a polyp, you may see a polycystic ovary, signs of endometriosis, fibroid, whether it is type 0, 1 as per the FIGO classification of fibroids. So all those things can be very well picked up. Endometrium, you see the patient say on day 5, 6, and endometrium is almost 16 millimeter, 18 millimeter. So first exclude pregnancy, and then you know that this is a patient with ovulatory dysfunction. So I think transvaginal sonography really tells us a lot. And similarly, if required, hysteroscopy can be done, especially when you are suspecting some pathology. Then in these particular cases, you can do hysteroscopy. And hysteroscopy should always be on a see and treat policy. So you should really take the consent in similar way, that if there is any polyp or submucous fibroid or anything, then you have really planned it beforehand, and this is how you are going to treat. Sometimes there may be just the products of conception. Patient might have had a termination sometime, and there are those product of conception which create the nuisance, and patient does not realize. And then you go in and you see these products are there, and you remove them, and then that's it. The patient gets better. So I think it's a very, very good tool to treat lots of small pathologies. Then as per guidelines, also NICE guidelines, you have to do check the woman for anemia and all to check her for any coagulation disorders. Ferritin test, they have said that all the women do not require ferritin levels. But if you feel that the patient is bleeding, her hemoglobin is normal, and you want to make sure that then in that case you can do ferritin level, which tells you a lot about the stores. Then even routine hormones like FSH, LH, these tests are not required in a woman under having menorrhagia. And guidelines says that NICE guidelines say that TSH is not to be done, but again this ACOG guidelines, they recommend TSH levels to be checked. And I also feel that in our country, doing TSH levels is a good idea. So we should check the TSH levels, and that may give us, and if required, then we can treat it. So it is a simple test, and treatment can be provided in time, and that improves the quality of life as well. Now, endometrial tissue sampling should be performed in patients who are older than 45. A transvaginal ultrasound is the initial screening test, and AUB and ultrasound, MRI, and all these are the second line investigations. Now, persistent bleeding with a previous benign pathology such as proliferative endometrium requires further testing to rule out non-focal endometrial pathology or structural pathology such as polyp or leiomyoma. And usually what I like to do is, if the patient is feeling a bit better in this cycle, and in the next cycle I want to reassess the whole situation, then I usually call her on day 5. By then, usually if there is endometrium, that would have shed, and if there is a polyp, then that becomes very prominent and the diagnosis gets very easy. So I'm very fond of doing a day 5 transvaginal sonography. Then this is an algorithm how you would like to investigate these patients, and then and depending on this, you can go ahead with your next treatment. Now, age-based diagnosis. Again, I think we have to tailor the investigations treatment as according to age also. So most at this age, most likely cause is the anovulation because of immature hypothalamo-pituitary axis. And this may be due to sometimes irregular use of contraceptive pill, pregnancy. It's very important. Even in teenage, sometimes it may be the pregnancy and she might have undergone termination somewhere and she still is having incomplete abortion. Or there may be pelvic infection. Coagulopathy is again especially very important in youngsters, or sometimes very occasionally tumors also. So 19% of the adolescents with AUP who require hospitalization may have underlying coagulopathy. So screening for coagulation disorders is very important in this particular group. And initial screening for an underlying disorder for hemostasis in patients with these heavy bleeding. It comprises all these things: heavy menstrual bleeding since menarche, or following PPH, surgery-related bleeding, or bleeding associated with dental work. So if she gives the history of these things, then it is very, very important to check the coagulation profile. And similarly, if she says that I get bruising very often, epistaxis very often, frequent gum bleeding, or family history of bleeding disorders. So all these, they demand a proper coagulation screening. Then at the age of 19 to 39, and here the most common cause is pregnancy. So very important to check for that. Then structural lesions like leiomyoma, polyps, and ovulatory cycles, especially in case of PCOS. Dr. Kaustubh Kulkarni was also talking that it is not only scanty menses always in PCOS. Sometimes there may be an anovulation, and endometrium may be very thick, and these women may have menorrhagia. Use of hormonal contraceptive, and endometrial hyperplasia. And endometrial cancer is less common, but it may occur, and especially in those patients who have had PCOS and amenorrhea for prolonged time, then in these women, they may have endometrial cancer. So especially in PCOS patients, I think it's very important to keep that in mind. And even in my practice, I've had at least 2 or 3 patients who have had endometrial carcinoma who were having severe PCOS. Now 40 years to menopause. Here, abnormal uterine bleeding may be due to anovulatory bleeding, which represents normal physiology in response to declining ovarian function. And it may also be due to endometrial hyperplasia or carcinoma or endometrial atrophy or leiomyoma. So this is about the various bleeding patterns. It may be cyclical, or it may be predictable, or it may be unpredictable. So if it is cyclical or predictable associated with heavy menstrual bleeding, then it may be because of adenomyosis, submucous leiomyoma, coagulopathy, and endometrial disorders. But if it is intermenstrual bleeding, then it may be polyp, iatrogenic, or sometimes it may be a sign of cervical carcinoma. And unpredictable is then you have to check for other things like tissues with like hormonal or issues with her ovulation or malignancy. So this is how this will guide us what to look for. And what is our goal? Goal is to control bleeding, prevent recurrence, preserve fertility, correct associated conditions, especially anemia. I mean, what we do, we try to correct just the bleeding, but at the same time, we have to remember that this patient may be anemic, or her iron stores are getting depleted. So we have to really prescribe her hematinics, and if the patient wants to conceive, then induce ovulation. And these are all the medical treatments which have been suggested since long time. Out of that, I think danazol I would like to skip, because I think none of us uses danazol for at least for menorrhagia. So estrogen progesterone therapy, if there are recurrent bleeding episodes, then combined OCPs can be given. You can give medroxyprogesterone. You can give medroxyprogesterone 10 milligram per day for first 10 days of each month. You can give it from 15th to 25th day of the period, or you can give from 5th to 25th day of period. If there are recurrent bleeding episodes, then you can use progesterone releasing IUCDs, that is levonorgestrel containing IUCDs, and these avoid the side effects, and they should be they cause 80, especially LNG-IUS, it causes 80% reduction of blood loss at 3 months, 100% reduction at 1 year, and has been found to be superior to antifibrinolytic agents and prostaglandin synthetase inhibitors. So the RCOG guidelines, they actually recommend use of LNG-IUS as first-line treatment rather than going in for other medical treatments. And if it is immature hypothalamic pituitary axis, as in young girls, then in these girls also you can give progesterone therapy. Even in older perimenopausal women, you can give cyclical progesterone therapy or low-dose oral contraceptive pills. Then NSAIDs can be given, and these are available as cyclooxygenase inhibitors, and they inhibit prostacyclin formation, and they can be administered throughout the duration of bleeding or for first 3 days of periods. And treatment results in sustained reduction in blood loss, so side effects tend to be mild, and most effective in ovulatory dysfunction, uterine bleeding. So danazol, I will try to skip. GnRH agonist, I think the only indication of GnRH agonist, I think, is where the patient is anemic, you want to buy some time, and in these patients you give hematinics, and then you can consider the proper treatment. So sometimes in certain situations, these can be given. Then inhibitors of fibrinolysis are tranexamic acid, EACA, and PABA. So what they do is mainly they try to balance between the prostaglandin F2 alpha, endothelin 1, and thromboxane, which are the vasoconstrictor and which cause the vasoconstriction and platelet aggregation, versus the prostaglandin E2 and prostacyclin, which is the culprit causing vasodilatation and platelet inhibition. And this is how the normal menstruation is achieved. So in heavy menstrual bleeding, there will be less vasoconstriction and less platelet aggregation by giving these agents. And in women with heavy menstrual bleeding, it has been found that the fibrin which is formed is unstable, and therefore there is heavy bleeding. And all these agents, what they cause is they cause the preservation of fibrin matrix downstream from the coagulation cascade, and therefore the periods tend to be light. Now, what is the dosage of tranexamic acid? And we used to think that it is 1 tablet 3 times a day, but going through the literature now, I've found that 2 tablets, 650 milligram, taken 3 times a day for maximum of 5 days during monthly menstruation can really help. And especially these women should have normal function. But if they have renal impairment, then dose has to be low. So if the serum creatinine is above 1.4 and less than 2.8, is about 2.4 and less than 2.8, then 1300 milligram 2 times a dose. And if it is above 2.8 and less than 5.7, 1300 milligram once a day. And if it is above 5.7, then 650 milligram once a day. So that is something we have to really keep in mind, that we should know about the renal function of the patient. And what are the adverse effects of the tranexamic acid? It may cause headache, musculoskeletal pain, sinus and nasal symptoms, and fatigue. And the contraindications are active thromboembolic disease and hypersensitive to tranexamic acid. And the drug interactions are minimal, and it can be administered with the meals, but it should not be used with estrogen containing preparation, because otherwise chances of thrombus formation will be more. So this is an interesting study on use of tranexamic acid, and here they have given 2 tablets 3 times a day for 8 months, and for women with heavy menstrual bleeding, and it is a multi-center double-blind parallel group randomized controlled trial. And what are the results? Results are that tranexamic acid provided quantitative and qualitative relief in women with menorrhagia, and it resulted in consistent improvement even in presence of fibroids. So that was one interesting thing. And more than 2/3 of women experienced clinically less periods, less than 36, that is equivalent to 36 milliliter, and a significant greater proportion of tranexamic acid treated menstrual cycles reaching mean blood loss volumes within normal range. And this group showed statistically and clinically significant improvement, and especially improvement in the quality of life, and improvement in menstrual blood as observed from first treatment cycle and maintained through the 6 months duration. And it is well tolerated with very few adverse reactions. And this is again a guideline that if the pelvic scan is normal and patient is trying to conceive, then the first line treatment should be tranexamic acid. Second line can be NSAIDs. Try for 3 menstrual cycles and continue if symptoms well controlled. If poor response, then try the second line treatment for 3 cycles or as appropriate. And if patient is not trying to conceive, then first line should be LNG-IUS. Second line should be oral contraceptive pill, tranexamic acid, mefenamic acid. And the third line can be injectable long-acting progestogen, oral norethistron 5 milligram TDS. So try for 3 months and continue if symptoms are well controlled. Otherwise, try second or third line as appropriate. So you have to really tailor the treatment as per the patient's requirement. So, and the surgical management involves treatment of underlying structural disorder with no response to medical management. Conservative surgical treatment in young women and also in women desirous of fertility. Hysterectomy may be offered as a last resort when all other options open. So I think nowadays the trend is to save the uterus. So we have to, and we have got very good devices, very good medications to treat these patients. So why increase the morbidity, the surgical morbidity? Why not let these patients have more comfortable treatment? So evidence-based good clinical practice recommendations for Indian women. Gynec Endocrinology of India recommends tranexamic acid in patients with abnormal coagulopathy also as a primary option. In AUB that is cyclical or non-predictable, or in AUB as first line therapy, in AUB due to leiomyoma, desirous of preserving the fertility, and in both acute as well as in chronic bleeding. And the NICE guidelines, what do they say? Treatment for women with no identifiable pathology, fibroids less than 3 centimeter or suspected or diagnosed adenomyosis. Consider LNG IUS in women with no identifiable pathology, fibroids less than 3 centimeters, which are not causing distortion of the uterine cavity or suspected or diagnosed adenomyosis. If women refuse LNG IUS, then non-hormonal treatment like tranexamic acid, NSAID can be tried. Hormonal would be in form of combined oral contraceptive pill or cyclical oral progestins. If treatment is unsuccessful, the woman declines pharmacological treatment or symptoms are severe, surgical treatment can be offered. Treatment for women with fibroids larger than 3 centimeters. If pharmacological treatment is needed while investigations and definitive treatments are being organized, offer tranexamic acid or NSAIDs can continue till they are beneficial. Other treatment options depending upon the nature of fibroid, and they include pharmacological treatment, uterine artery embolization, surgical myomectomy, or hysterectomy. So my conclusion is that evaluation and management of women who present with abnormal uterine bleeding is broad and depends on patient's presentation and her treatment preferences also. Patient should be thoroughly evaluated for underlying etiology for the bleeding, which will further help in determining what sort of treatment option would be best suitable for her. It is considered best practice to start with least invasive methods, move forward with more invasive approaches like surgery, only if other options have failed. So thank you very much for the patient listening, and I would like to request you all to vote for me as a Vice President candidate, West Zone Foxy. And the voting has already started, so please do exercise your right to vote. And I wish that this corona crisis is over soon. And me as organizing chairperson of AICOG and the whole team of IOGS is ready to welcome you all to Indore. Thank you very much again for the patient listening.
Thank you so much, Dr. Asha ma'am. It was really a very wonderful talk, and with all points covered in 20 minutes about AUB is really difficult. I really thank you for that. Let's move on to our next session. I would like to invite Dr. Manish Machave, sir. Dr. Manish Machave, he was Vice President, Pune Obstetric and Gynecological Society 2019 and 20. He is Chairperson of Ethics and Medical Legal Committee of FOGSI 2020 to 22. He was member of MTP Committee of from Pune. He is a founder, member and treasurer of Pune Association of Gynec Endoscopic Surgeons. He was the organizing secretary of AMOX 2018, organizing secretary of Star International Conference of Endoscopy 2018. He was the first from Pune to be awarded the prestigious FOGSI Padma Shri Dr. Kamini Rao Oration Award in 2013. He was conferred Dr. Indirabai Khare Oration by Nagpur OBGY Society in 2013. He has given more than 1,500 deliberations at national and international events, and as a convener also of endoscopic and medical legal workshop. I welcome Dr. Manish Machave, sir. Dr. Manish Machave today will be talking on a very important topic of medical legal cases, lessons learned. And we all know Manish sir gives a beautiful talk on this topic. I welcome you, sir.
Hello, thank you so much. Respected Nandita madam, Asha madam, I can see Girija madam here, and all the speakers. Thank you, Rohan, for this opportunity. Can I share my screen?
Yes, sir. Yes, sir. You can.
Manish, we are proud of you always.
Thank you so much, ma'am. You are there to guide. So, my screen is seen.
Yes, sir. We can see your screen very clearly.
My screen is seen.
Yes, sir. We can see it.
All right. So, thank you for this opportunity. Yeah, thank you for this opportunity. At the beginning, I have to, put a very strong request that I am required in another webinar. So I'll finish this talk really fast and take only obstetric cases. I pray to Lord Ganesha to sail me through this presentation. And I always say that whatever I am today is all because of the hard work by my teachers, and Girija madam is one of them. So much to learn from them. Asha madam is there, Nandita madam is there. So thank you for inviting me here to give this talk. This is me. So landmark cases, lessons learned. There are a lot of landmark cases. What we will do today is we will go through some obstetric cases and maybe skip the others. Few basics we have to understand that in this era of COVID, especially, and otherwise also, do not take whatever comes on WhatsApp as a sacrosanct thing, because anybody put anything on the WhatsApp, and suddenly our perception of law or our perception of medical legal things change. Please understand that these WhatsApp messages and sending wrong kind of messages is not correct, and do not follow them. We have different codes, so this is very basic to understand. We have criminal, civil, and consumer codes. Whenever there is a case, the case is made up of allegations and defenses. There are expert opinions and evidences given for that case, and the judgment is limited to that case only. So, for example, if a judgment says a particular thing about a case, that does not mean that the judgment is applicable to everywhere and all of us all over India. How do we learn? We learn from the ratio decidendi of a case, which means the reason for which the judgment was given, and obiter dicta are some comments which the judges would pass, and that would give rise to formation of new laws. Point number one, which we have to understand very clearly, is ignorance of law is no excuse. So you cannot say that I didn't know that this was supposed to be done, or I didn't know that that was not supposed to be done. So ignorance of law cannot be an excuse. It is not a defense. So some cases I will skip. Again, I request your pardon for that, because now these are some cases which have taught us a lot of things. So there was a case of Nizam. So the first case which we skipped was VP Shanta's case, where because of this case, the Indian Medical Association lost this, and medical fraternity came into CPA. Then from Nizam Institute of Medical Sciences, we learned that we have to involve competent person for help whenever it is required, and calculation of compensation is totally and completely up to the judges. From Martin F. D'Souza, Muhammad Ashfaq, we learned that law, they said, is not is a watchdog. It cannot be a bloodhound, so it cannot run behind doctors. Otherwise, the doctors will not be able to give their best, and reasonable care, which is the Boehm's test, and guidelines to investigate. So if there is a complaint, police complaint against a doctor, then there are certain Supreme Court guidelines which the police have to follow. They have to get an expert opinion from doctors, and the doctor may not be arrested unnecessarily and harassed. So there are, so many cases which have come out with these small things which we have to remember. So, for example, Suresh Gupta's case, the Supreme Court said that for criminal liability to be fastened against doctors, the liability has to be gross. The negligence has to be gross and reckless. Otherwise, it can go to, consumer or civil court. In Jacob Matthews, we learned the difference between civil and criminal cases. And again, the point that to fasten a criminal liability, the negligence has to be really gross. And what is required from doctors is the skill possessed by an ordinary person, and not of skill possessed by the best of surgeons or the best of gynecologists or best of obstetricians. Now, this is one case, Samira Kohli versus Prabha Manchanda, and this case, we all know, it was a laparoscopy done for endometriosis, which ended up with an abdominal hysterectomy because of bleeding. Now, what do we learn from this case was the concept of informed consent, and this is the skeleton of consent that we are supposed to take: date and time, patient-related factors, doctor-related factors, witnesses, disease-related factors, surgical procedure-related factors, anesthesia-related factors, blood transfusion, a separate consent is required, anesthesia, a separate consent is required. And we have to also document that the patient and relatives were allowed to ask questions and their queries were solved. And this is how the consent for anesthesia has to be taken. So I'll skip these few cases and we'll go to some obstetric cases and we'll see. So this is a primary gravida full-term pregnant patient admitted in labor. The patient, as usually the doctor tells the patient asks if everything is okay, and the doctor told that she will deliver vaginally, and the husband had gone out to get some medicines, and during that time there was fetal distress and emergency cesarean had to be performed, and the patient died during surgery. Now, here the cause of death given was cardiorespiratory failure due to pulmonary embolism. And allegation of the husband was that I had gone out, there was no consent, and they did a section, and the patient died on table. Now, we have to remember that whatever doctor does, and this, all these are real life cases, whatever a doctor does, if it is done in good faith, following all protocols, and proper documentation is kept, then negligence is not proved against you. So this is a real life case where the court said that the unfortunate development can take place and the patient may have died, but the doctor did everything. The husband was contacted on phone. Everything according to protocol was done, and there was no negligence. So again, what we learn from this case is that if you follow the protocols, do everything properly, done in good faith and well documented, will save you. 28-year-old primary 40 plus 4 weeks labor was induced with oxytocin. ARM was done, baby delivered, patient was discharged. The baby was readmitted on the same day with fever and convulsions and breathing difficulties. Baby was diagnosed as having hypoxic ischemic encephalopathy, septicemia, and was in ICU. The baby later on developed mental retardation, recurrent epilepsies, and physical difficulty in walking and dependent on parents. Now, this is what the court observed. The allegations were high-risk pregnancy. It was a post-term pregnancy. Oxytocin drip could have caused trauma. In the notes, it was written that when ARM was done, very little liquor came out. So was case of oligohydramnios, and cesarean section done was better. And 4.5 lakh rupees compensation was given. Now, what we learned that, and court also maintained that it was a high-risk case. Again, everything comes down to documentation. So you have a post-term pregnant where you're inducing with oxytocin drip. Your documentation with respect to monitoring of oxytocin drip has to be very good. Your documentation with respect to if you have done ARM and there was oligohydramnios, you have reassessed your case. Doctor should have preferred cesarean over normal delivery. That is what court observed. Oxytocin drip was not monitored because it was not, put there on the documents, any monitoring chart. It was not there. Pediatrician visited 1 hour after birth should have been called earlier. Res ipsa loquitur principle is applicable. Now, this is what we learn. So now the question arises, should there be a neonatologist or a pediatrician for every delivery? FOXI guidelines say that it is prudent to call a neonatologist whenever available. For high-risk patients, yes, you should have a neonatologist there in the labor room when the patient is delivering. Otherwise, a person who has adequate training in neonatal resuscitation till the neonatologist is available can assist or help you. For routine cases, it may not be necessary every time, but somebody other than the obstetrician who can manage the neonate should be there in the labor room. Now, what is res ipsa loquitur? This is something which we have to understand that the action speaks for itself, or thing speaks for itself, and there are no defenses when res ipsa loquitur is put. Generally, this is put when you do a surgery without consent, or surgery on a wrong patient, or if there is a foreign body inside, or there is a criminal abortion or transfusion of wrong blood. Now, patient after cesarean continued to have pain. Ultrasound revealed a foreign body operated by another doctor. Napkin size mop is found. Now, in such cases, it is very difficult to be very careful with your mops. A good mop count, a post-op checklist will help you. If there is a mop, you can have a radio opaque line on that. Generally, what mops we use, we have a sort of one string attached to it, which is put to an artery forceps, which is outside. Mostly try and use suction so that your assessment of blood loss is also good, and avoid mops as far as possible. Sponges, metallic clip of suction, cannulas, artery forceps, so on and so forth. So many things are found inside, and it becomes very difficult to manage. Again, there is something inside now. This is a case who should and can do an out-of-court settlement. Scissors were left inside during cesarean section. Defense was because there was failure of power supply, so scissors were forgotten. Now, this is complete negligence. So this is one case where you should do an out-of-court settlement and not go to court. Cesarean section done for large baby. Baby suffered paralysis of upper limb due to excessive traction. Now the point here is that when we do a cesarean section for breech, or when we do a cesarean section for a big baby, you need to remember that the baby has same risks of trauma as with vaginal delivery, because the incision on the uterus will have the shoulders they can get stuck there, or the breech, you have to know all the maneuvers because those are also required for delivering the baby at cesarean section. Now here what happened was, when you give a part of a chapter as an evidence, you need to read the entire chapter. A Mudliar and Menon's textbook, a part of that chapter was given as evidence, which showed that, with shoulder dystocia happening, and there can be injury to shoulder, and it happens in so many percentage. But in the same chapter, on the next page, it was written in expert hands, this is very uncommon and should be, should not happen in routine practice. Now that is why you should read your references very carefully, because this is what the advocate of the doctor gave, and the opposite party's advocate found out on the next page what was written, and 1.75 lakh rupees of compensation was awarded. Primary gravida, full-term pregnancy, uneventful delivery, discharge after 24 hours. Baby brought back to hospital 2 days, diagnosed as infection. Was referred to pediatrician. Pediatrician saw the baby and asked one of the assistants to give some injection. After second injection, baby had spasms and collapsed and died. Now, this is a very important principle of vicarious liability. So whoever, junior doctor, sister, staff nurse, whoever is working for you, you are responsible for their actions with respect to compensation. So with respect to a case being done, or case being run at criminal in consumer court or civil court. For criminal actions, vicarious liability principle is not there, but definitely for compensation. So be very careful in what you tell your juniors. Be very careful in how your juniors, do their duties and whether they are using, because there are so many injections which look similar, their trade names are similar. So you have to be very careful, because final responsibility lies with you. Emergency cesarean performed, patient developed complications, concerned doctor was not available, another doctor was summoned, he tried to revive, the patient died on the same day. District Forum awarded 3 lakhs rupees, State Forum set aside the order. Appeal by patient's husband, hospital record showed patient died of amniotic fluid embolism. Now please understand, if you are not available, a competent doctor should come and manage the patient, and there is no negligence in this case. No negligence was found just because the doctor who operated was not there to manage. So whenever you go out on conferences, maybe holidays, wherever, you should understand whom to keep locum, when to keep, how to keep. So there is a way of informing the patients. In your reception, you can put a board, so and so doctor is available, maybe share his phone number. And all these things about locum you have to understand, and all these things if you have done properly. We have had a case when in one of our AMOX conferences, a doctor couple had come, and then one of their patients died, and this case is still going on. So a good locum, a correct locum will go in a long way to help you. Again, cesarean section was done, no blood was arranged, relatives brought donors. Now this is not the time, when the patient is bleeding for you to get donors. Oxygen cylinder was not available, it was brought from another hospital where the relatives only were sent in rickshaw to get that cylinder. The surgery went on for 7 hours, shifted an unstable patient to government hospital, died en route. Now in this case, if you see every sentence, there is negligence. And it is very difficult to defend this negligence held and compensation awarded. Now, even if you see the compensation may not be much, but then these cases become a precedent. These cases are cited in the courts. These cases, make the general public, society have the kind of look and the kind of opinion about doctors for which, we are trying to change the societal norms, societal view about doctors. And this is something which gives rise to a sort of friction between the patients and the relatives, and doctor bashing and bashing of the hospital and vandalism and everything comes in. So if you cannot manage a patient like this. If there is no blood, no oxygen cylinder, you should not do a cesarean section. Refer the patient in time. In such a hospital, doing a surgery for 7 hours is absolutely not done, shifting an unstable patient. So that is why I said every line there is negligence. Failure to detect twin babies on ultrasound. Ultrasonography test was wrong. Complainant prevented from taking extra clear, and the defense given was obesity. Now, I understand a lot of us do ultrasound, and in your ultrasound, you have to mention disclaimers like, obesity is one, amount of lacquer is one, position of baby is one. But somebody who's coming to you for ultrasound for 3 times, you cannot miss a twin pregnancy. That becomes very difficult. Deficiency in service proved. Opposite party liable to pay compensation. So be very careful with what kind of ultrasound report you give, because now more and more compensation is being given to wrong ultrasound reports, and a lot of these cases come, and again it is not an easy job for us to defend. Ultrasound report of fetus being normal. The newborn baby had no left upper limb part of forearm. Complainant therefore attributing negligence on part of doctor, directed to pay damages of 10 lakhs of rupees. Now, if you miss something which is gross, so you have to divide anomalies or divide problems into some which you have to diagnose and some probable or maybe missed. So that kind of situation and missing an complete upper limb, and then it becomes a problem, and a compensation which is given is huge. Defense is taken where ultrasound is not 100% proof and limitation that the fetus can. But then again, the problem is that you have to persistently write those limitations in the reports and prove that, because onus of proof or burden of proving the problem is onto you. Now here again 6 lakhs of compensation were paid. Missed on sonography, absent kidney and limb, defense oligohydramnios, not 100% science. Obtained expert evidence in favor of doctors. So there are a lot of sonologists and seniors who wrote down in that expert evidence affidavit that this can be missed. Still 15 lakhs of compensation were awarded. That means that the forums are not bound in every case to fall in line with experts. So even if you get an expert opinion, not necessarily that the forum will follow. Now, these are some rapid fire cases we'll go through, and I'll just tell you the zest of it. So from Permanent Katara case, we come to know that in case of an emergency, the medical colleges have to take a patient. You should also take an emergency patient and treat it. From state of Haryana versus Rajrani, we learned that female sterilization is not 100%, and there can be a case where it fails, and it is the responsibility of the patient to come and show the doctor. Table death, informing the police is a must if you do not know the cause of death, and then the police are responsible for getting a PM done. MD Freiberg, a German degree, is not equivalent to an MD or a DGO. It is equivalent to MBBS. So, you have to be very careful with this. Scissors forgotten is res ipsa loquitur, as I told you. Again, Spring Meadows Hospital versus Harjal Ahluwalia is another case of vicarious liability where chloroquine was given IV instead of chloromycetin, and hypoxic brain damage happened to the baby who had fever. Free eye camp post there is infection, and compensation had to be given to the victim. Homeopathy doctor practicing allopathic medicine is crosspathy, negligence per se, no further proof of any negligence is needed. Anesthetist is also liable if there is, and initially it was considered that only the consultant is liable. No, if anesthetist is also liable, he is also one of the doctors who is treating the patient. And there is a issue of rule of locality. Standard of care depends on locality of practice. So if you are practicing in big city, your standard of care is way more than somebody who's practicing in a village or a district or taluka place. Now here the hospital was held negligent for keeping it unclean because a maternity patient slipped and died, and 2 lakh rupees compensation. So you need to be aware of all these things from all sides. Denial of treatment in government hospital for non-availability of bed is violation of Article 21. So if you need to shift a patient, you should shift a patient to a government hospital where they will always take the patient and can never refuse. So these are few things which I wanted to share very fast. You in your practice, put stress on valid consent, proper investigations, take due care for treatment and surgery. Documentation goes in a long way. Expert opinion at times may not be of value because it depends on the judges to accept or not, and obviously local level medical legal cells help. Bolam test is something which I said a test what a reasonable man or a reasonable doctor is expected to do, and Bolito principle is again it is opposite to Bolam. So our courts are now in between these two. So a lot of Western courts have now accepted the Bolito principle, where even though there is a professional opinion, and as I showed, the expert opinion was there, still the court did not accept the opinion, and they will value or they will see how much that expert opinion is important. So thank you so much. I had to run through these few slides because I have to again, with all due respect, I have to run to another webinar. So thank you so much for this opportunity.
Thank you so much. It is always a pleasure to hear you and listen to the cases and take the guidance from you. Thank you so much, sir, for taking out time. And I would like to thank everyone, the Sun Senora division, Sanam Shah, Rashmi, and all the speakers and the faculties to take out time on a Sunday and have such a wonderful session. I would also like to thank Dr. Nandita Palshetkar, Dr. Rohan Palshetkar, to involve all of us and to arrange such a beautiful webinar.
Okay, thank you. Thank you
Thank
so
you,
much.
everybody.
Thank you.
Thank you.
Thank you.
Welcome.
So nice of you, sir. Thank you, sir. Thank you, Madam Girija, Madam.
Very much.
Thank
And
you,
thank
Vidya,
you,
Madam.
Senora, for giving us this wonderful, forum so that we could connect to each other and all of you. Thank you.
Thank you very much, Doctor, for your kind support. Thank you very much. Thank you, Dr. Jitika, for wonderful
Yeah,
moderation of
thank
the
you,
program.
Sapan, and thank you, Mr. Soman. Thank you, everyone.
Thank you, Jitika,
I think
Madam.
Dr. Rohan had some emergency cesarean, so he had to leave. So I thank everyone on behalf of Dr. Nandita also and Dr. Rohan also.
And don't forget to vote. Today is Sunday. Please go and vote. 24/7, the window is open. Thank you.
Thank you, madam. Thank you so much.
Thank you, Madam. Thank you.
Kishore ji, we can close.
Yes, sir. I'll close. Thank you, sir.
Thank you.